Good morning and welcome to the 34th meeting of the Health, Social Care and Sport Committee in 2025. I've received apologies for today's meeting from Paul Sweeney. The first item on our agenda is for the committee to agree to take items 6 and 7 in private. Do members agree? Thank you. The second item on our agenda is to take oral evidence from 2 panels of witnesses as part of the committee's Stage 1 scrutiny of the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill. Our scrutiny of the bill this morning is specifically focused on Part 1 of the bill. The first of this morning's panels comprises witnesses from healthcare representative bodies and professional regulators. And I welcome to the committee Jacqueline Cooney, Director of Scottish Medical Aesthetics Safety Group, Stefan Sheranowski, Executive Director of Strategy and General Dental Council, Amanda Demosthenes, apologies if I've not pronounced that correctly, Non-Executive Director and Board Member of the British Association of Medical Aesthetic Nurses, and Remy Jones, representing allied health professionals in aesthetics. And we'll move straight to questions, and Sandish Gohani.
Thank you, Convener. Just declaration of interest as a practising NHS GP. Good morning, panel. Thank you for coming in today. I want to start by asking a very basic question. The procedures that are sought to be regulated, are they completely safe, or do they pose some form of risk to the public?
Risks, yeah. You know, the worst ones being necrosis, vascular occlusion, death, sepsis, you know, burns, scars. There's a whole, range of different complications that are pertinent to patients and that we see quite commonly in our practices as well.
One of the most simple things that people think that a GP will see is a cough and a cold, and that's normally quite innocuous, and you examine the patient. But would we let just anybody examine a cough and a cold, somebody who has no regulations whatsoever? And the way that I'm framing this is that a similar way that we could look at even some of the most minor procedures which are covered under this bill?
I would agree, yes. I think that some of these procedures carry high enough risks that you just wouldn't want anyone, just a member of the general public, even if it was someone that had done a day's course on something. For, in my opinion, it's just not enough of robust education behind it to be able to see those things and treat them. So years of experience from doctors, nurses, other healthcare professionals will see them through to be able to do these treatments and treat any complications that may occur from them. But yeah, I would agree. I don't think we should just allow anyone to do, I would say, the majority of those treatments that are in the groupings.
I mean, I've spent years as an orthopaedic registrar training how to operate, and I wouldn't be allowed to independently take off even the smallest lesion within a hospital setting. So it does seem a bit fraught. Stefan, if I could turn to you, if I may. In England, the Dental Association didn't want to be part of the regulations and be part of the group which covers people who could be doing these procedures. Is that a different take that you have in Scotland, and if so, why?
I don't think we do have a different take in Scotland. Dental professionals are, in the terms we were just discussing, they are highly trained in the range of procedures, and it isn't just, particularly for dentists, it isn't just about precise issues around oral health. So they are well placed as health professionals to do the job of a health professional. Obviously, as with any procedure, it is the specifics of the procedure, the specific risks around it need to be understood, and it won't be part of a dental professional's normal training to have covered the range of procedures that are the focus of this bill. So I think there's a distinction between are dental professionals as healthcare professionals well placed to act in that role, and do all or some of them have the appropriate specific knowledge and skills and experience to act in relation to these procedures? In
the list of organisations and regulators that Dental Association is certainly one of them. Is that a position that you're happy with, or do you want that removed?
I think generally we are happy with it. I think the issue is less about the role of the healthcare professional, and particularly in an overseeing or supervisory role. I think our concerns are much more about the people who may not be healthcare professionals who participate, particularly in level 2 procedures. So the relationship doesn't really exist in other settings of that kind. And I think there is potentially an issue of whether you get sufficient regulatory confidence from the role of the supervising healthcare professional, which in a more normal clinical setting, you would expect every member of the team themselves to be a professional registrant in their own appropriate category and with their own appropriate regulator. So you've got a chain of accountability. If we have lay people conducting these procedures with potentially limited training, and certainly on the current approach for level 2 procedures in dental settings, the non-dental professional would be under very limited requirements to meet any particular standards. So in an odd way, those individuals would be potentially less regulated than the people conducting level 1 procedures under the civic government powers. And I think it is that how much weight it is sensible to put on the professional role of the supervising healthcare professional and the regulatory system that they're part of, to be confident in the specific activities that are going on under their supervision.
Okay. Sorry, does someone else want to?
I think we were just nodding.
Okay. Remy, if I may come over and ask you some questions. So you represent allied health professionals. Now, I think it's very important that we say this is not lay people, these are allied health professionals. What is your opinion of the bill, especially when it comes to patient safety and clinical oversight?
I would have to say that I concur with the comments that have been made previously from my colleagues here on the panel with regards to ensuring patient safety. Clinical oversight, I would have to agree that a professional registration to me would be the most appropriate grounding for that clinical oversight. But furthermore, I think that more than just having a simple professional registration would be beneficial. So as a paramedic that has taken the postgraduate diploma in aesthetic medicine myself, so I have taken the extended education, I feel that that, to me, pertains to the most sufficient amount of education I could possibly attain to get. So I think it's more than just having a professional registration. When we're talking about that specificity of clinical oversight, I think we need to have the specifics of aesthetic medicine in that clinical oversight rather than a generalist medicine registration, for me, based on the experiences that I've had.
And given your extensive training, do you feel that you would be in a position to offer potentially, obviously no one does, but potentially everything within the scope of this bill?
Yes, based on the training that I've had to date, it was extensive training. I also undertook an extensive period of mentorship as part of that training to ensure that I was both clinically competent in all aspects of consultation, assessment, history taking, specific to aesthetics and the medicines that we're going to use, but also about the psychology behind it, law and ethics around it. So for me, it completed the package rather than being, you know, a generalist aspect. It was very specific to the job in hand. So, yeah.
And my final question, we spoke a lot last week about HIS-registered premises. So we look at dentists, obviously, the dental room and the place that is going to be regulated quite tightly. Now, given that we spoke earlier about how there is a risk associated with all procedures, and we spoke about how we need to ensure that there is the utmost patient safety, what is the panel's view on whether we use HIS-registered premises to perform these procedures?
Specifically on your reference to dental premises there, because that summary that you've given is generally true, but not wholly true in respect of dental practices. The vast majority of dental practices are not inspected and regulated by HIS, because any dental practice that carries out even a small proportion of NHS work has that work overseen by the NHS boards. And as a result, it is only a very small minority of dental practices that do have that HIS oversight that you were referring to. And I think that is a gap. It's been a gap that's been around for a long time generally. In the other three nations, the systems regulators don't distinguish between premises in which NHS work is carried out and premises in which independent practice is carried out. But the role of HIS is more limited. So that, I think, has been a regulatory gap in any case. I think the provisions of this bill risk emphasising that gap, because we will be faced with a situation where the majority of dental practices, which would be appropriate premises for the activities governed by this bill, would have their NHS work overseen by the boards, but their interest does not extend beyond the NHS dental work. So there would be no premises or systems oversight of activities conducted on those premises that were not NHS dentistry.
I just wanted to say, I did a little bit of data capture around, looking at how many complications there were, because it is quite difficult to actually quantify the number of complications that present via, NHS trusts, etc. And I managed to get some data from SafeFace and JCCP, and there's roughly around 2,800 complications present across the UK. That's not Scotland based, but roughly we can work it out, about 700 complications across Scotland. So I think having a HIS registered premises protects that a lot, because you've got, oversight, you've got regulation of the premises, the practitioner themselves has some regulation anyway. So I completely agree from a nursing standpoint that HIS is a good, standard to set across the board, because if you don't have a standard, there is no standard. No one's going in to check these premises and, see what clinical settings people could be operating from a garden shed. It becomes very tricky. So yeah. I think Jackie would agree as well from a nursing standpoint.
I also have data from the Scottish Ambulance Service, and I have got data which Caledonia University had dug into, and they did FOI requests to the Scottish Ambulance Service, and I think there was something like over 1,000 ambulances called to premises that had the name aesthetics or clinic in the title. When they dug into that, they looked closer at it, and as they dug into it, they realised that nearly all, the majority, bar two, were non-medical establishments that they had been called to. And the ambulances that had been called, which carry a cost, and not even just a financial cost for the ambulance, but there is a wider cost to the general public, because someone else is waiting on an ambulance when an ambulance is called when it's not particularly needed. The things that they were called to, the items that they were called in for, were things like palpitations after having lip filler, maybe a faint. So when we go back to your question about the HIS regulated clinics, then if this happened, if something like that happened in a clinic where I was in and it was HIS registered with oversight of a medical professional in the place, then none of those ambulances would have been called, because Amanda and I and the rest of my colleagues in this panel here have got the ability to deal with a faint or deal with a palpitation or a panic attack after a needle has been inserted into someone's face. So all of those wider implications would not have been, a risk factor as well. So HIS regulation, much as sometimes they can be the bane of our life with the overzealous regulation that they do, it is robust and we welcome it, and I would not have it any other way. I think it's a safe way forward.
Yeah, no, I would agree. I've come from England today, so I'm used to the CQC rather than the HIS, and I'm here last minute, so apologies for some of the differences that I may not be completely aware of. But in the same way, in the UK, we have CQC regulations. Currently in England, we don't have to necessarily be CQC registered for certain types, which I believe is the level 2. treatments that are undertaken, and it's only those more complex and higher risk treatments that you would require the CQC registration for. So, in my opinion, I think the emphasis should be placed onto the practitioner and their skill set, and I do believe that the premises licence would be important as part of the licensing. But the JCCP also offer fantastic, I'm a member of the JCCP as well, and they offer a fantastic support guidance on your licence for premises as well. So when you register with the JCCP, there is a practitioner licence and a premises licence that are combined. And I would imagine that they sit fairly similarly to what would be the expectations of HIS around the health and safety aspects of a premises. So there are perhaps, I suppose my point is, there are potentially other options other than just having a HIS registration. If we were to use something like the JCCP as a stance or a governance point, they also cover premises within that registration.
I would like to add though to that because of HIS and because of where they sit in the regulatory framework, they registered the clinics as independent medical services, and because of that registration, of how it was registered or how our clinics are registered, nurses in Scotland can have access to a stock of medicines because of the way that the clinics under HIS are regulated. So I wouldn't see that any other regulator would be able to do that because of the position that HIS are in that regulatory framework. It allows us ease of access. So the clinic holds a stock of medicines, which means that nurse prescribers within that clinic carrying out the duties of the clinic can gain access to those emergency stocks or any stock of medicine that is required within that clinical setting. This is not the case elsewhere in the other 3 nations because of the regulation. So it is down to our HIS regulation in Scotland that allows that to happen. And I feel that that allows safer access to medicines to the people who are using the services within the clinical setting.
Protects the patient more, doesn't it?
Yeah.
Sorry, I'm just going to come back on that because I'm not sure if you're aware that there is currently an initiative by ACE World Group. I don't know if you know about ACE World Group, who are implementing PGDs for healthcare professionals to be able to hold emergency stock of medicine, to be able to, treat immediately for those healthcare professionals that are non-prescribers, so that they are still able to provide emergency treatment should they require it under a PGD. No, it's not. It's not in place yet. They are going through. I sat on the board to support the PGD as a paramedic expert, and we did that back in April of this year. And I believe they are just waiting for their registration with the CQC specifically for this initiative to come through. So it's gone through a robust legal investigation, and that's fine. As I say, they're just waiting for the actual registration to come through so that they can start to implement this to their members specifically.
I think the only difficulty with that is, and it's great that that is happening for the other 3 nations. I think it's fantastic that that's happening. However, the other difficulty is that it's for emergency medicines only. It's not for all of the medicines. And in Scotland, we can hold a stock in the clinic of all of the medicines that you need. So if it was antibiotics, if it was steroids for swelling, and these things are more... Sorry.
We've got limited time.
Yeah.
And
Okay, sorry.
could you please direct your answers directly to the questions from the committee?
All right, okay.
Thank you.
Sorry. Yeah.
That's a final question, yes.
Emma Harper.
Thank you, Convener. Good morning to you all. I'm wondering if the bill provides enough clarity on who can perform the procedures listed in Schedule 1. And I was looking at the procedures, and it's things like threading, microablation, injectable Botox, for instance. Is there enough clarity on who can perform the procedures that are listed there?
It's the training behind them, I think, that comes really into question around the level of training, because what we see out in practice is people go on a 2-day course, and it's mainly compromised. Jackie will give you some more stats on this afterwards, but around the business skills and not the clinical side of things. So then these people are then, you know, deciding that they're competent or able to do these injectable treatments. And in reality, it takes years and years in practice to be, you know, good at doing these procedures and get good results, as well as know how to deal with, you know, many of the complications that come off the back of it. And obviously, your nursing background, your dental background, your pharmacy background, whatever your background as a medical professional is, prepares you a lot more to deal with a lot of the side effects that we actually see in practice. Whereas if you've just done a 2-day course with no prior training, I don't think it is clear, you know, who that person is going to be that's doing the injectable treatments and their level of clinical competency to deal with reactions, complications, bad results, you know, because that's another thing. Undesirable results comes up a lot, you know, and is that a complication for the patient? But they are quite scarred by it, and they will come in and be very upset about it, all the way from that to the more major things that we see, you know, permanent scars, vascular occlusions, necrosis, you know, all these things present off the back of these treatments. So I think it's a very broad category to say, you know, who is able to do that under supervision. And I think, you know, that's where the grey area really lies.
Is there a grey area between supervision and management? I mean, does supervision mean I'm watching you over your shoulder?
Yes, exactly.
Versus I'll be in the next room and give me a shout if you need me.
And my worry is that we will end up in a situation where one person is supervising 100 clinics, and who's checking that? Because you can't be in 100 practices in one go in all reality. So I think supervision is really, for me, a very foggy term, and I think it needs a lot of clarity.
Oversight needs to be, I suppose, drilled down into numbers. How many people could I, you know, feasibly in this room, if every single one of you were injecting and I was responsible for giving prescriptions to all of your patients, how could I possibly have eyes on every single one of you injecting? And all it would take is one of you to have a complication, and then I would be caught up with the complication as the medical person overseeing, and I couldn't then, everyone else would have to be tools down because I couldn't possibly be in with every single person. When you look at COVID, vaccinations or vaccination centres, there is a level of a ratio of how many trained members of staff there should be to maybe band 2s in the NHS, or band 3s to do the injectables with vaccines. So there's, I think it's a 1-to-3 ratio with pre-drawn up syringes, but it's a 1-to-2 ratio if it's drawing up from like a vial. And I don't know how well that works in practice, but certainly that is what is written down in paper that it should be done like. Now, all of those vaccines don't carry the same risks as some of the injectable treatments or laser therapy, burns and whatnot that happen in all of those groupings. So I feel that the level of oversight needs to be robust. Not only that, I feel that the level of oversight has to be appropriate. So, for example, I think your colleague asked a question, would you feel competent to deal with all of the treatments that were on that list? I personally would not feel competent dealing with every single thing on that list. So, for example, if someone was using a cryopen to take like a lesion off of a face, are they competent? Do they have a background, even if the medical person was overseeing? Do they have a background in dermatology? Do they know how to recognise a cancerous lesion? Or would they tell that person to go ahead and zap that off? Because the person who's giving the oversight has to also have appropriate qualifications to be able to give that oversight.
So I just wanted to say it's quite important also that those processes don't just become a transactional meeting between the patient and the prescriber or the clinical oversight person, because it's important for the patient that they have continuity of care from the point of consultation, assessment, right through to the treatment. And there's a risk, I think, if we have a clinical oversight person that is obviously trying to look after a larger number of people, we're not getting that potential continuity of care for the patient throughout their whole sort of treatment.
A lot of people that are seeking to have dermal fillers hyaluronic acid or Botox, they don't consider themselves patients. You know, so that's something that has come up in our papers as well. So I'm wondering about, like, are we creating a whole medicalised approach? And I mean, being careful in what I say, because I am a registered nurse. I worked in the operating theatre. My job was, you know, it was anaesthesia, looking after people, liver transplants, things like that. So it was very invasive in terms of surgery. But I'm trying to think about the people that are practising already, that are very experienced. They've gone through lots of training. They're quite effective. They would consider themselves competent. So how do we match up the requirements for training and supervision and competency? Because when I did the COVID vaccines as a nurse, I was seen as competent to drop my own meds, even the pre-filled syringes. That's fine. But it was once you're supervised and competent, get on with it, Emma. That was how it worked.
I totally see your point there, but I think they don't see themselves as a patient. I agree sometimes, but until there's a problem, and then they present in practice, and then they definitely see themselves as a patient. And what we hear is, off the back of treatment, they've not had consent processes, they've not had aftercare. I've even had practitioners actually blocking the patient when they're dealing with permanent scars, and then the patient's coming in, obviously then to be picked up by a medical professional because they don't know where to go. And they're extremely distraught at this point. They've often had time, you know, weeks out of work, a lot of, you know, psychological distress because they're going in for something that they see as not a procedure when it is a procedure, if that makes sense. So I think there's a misconception there in terms of how it's been pitched to the patient as a beauty treatment, but I would absolutely argue these are medical procedures that carry, you know, quite a high level of risk in some cases. You know, like I say, varying degrees depending on what we're looking at, but there is high levels of risk, and they do definitely feel that they are a patient at the point of them coming in to see you to say, you know, I'm now seeking legal advice because I've got, you know, necrosis or scars or something that's come off the back of this treatment. So I agree. I think they're vulnerable. The patient is vulnerable, and I think, you know, when it comes to patient safety, all that's happening now is we're giving them a level of protection which hasn't, you know, been there as much as, you know, it could have been in the past. But I think, yeah, I think looking at other countries and their models and the way they operate, they are very much seen as medical procedures, and I think there's maybe been a slight misconception that this is beauty.
We've demedicalised it almost. So we have over years demedicalised what we believe to be medical treatments. I think it's also fair to say that in HIS regulated clinics at the moment, even a non-prescribing nurse would have to have a level of oversight and have to have a prescriber present. So it's not just about, I suppose, to suggest that we're HIS registering people who are non-medical. We also have to HIS register people who are medical, and the people who, and we do that, and we've been doing that since 2016. So since 2016, we have been regulated since that time, and non-prescribing nurses are under the same, I suppose, what the new legislation is suggesting. We're already under that as non-prescribing nurses, that they will be under that level of oversight. So yeah, I think we risk demedicalising what is known as a medical treatment, because it is, we've got to respect the fact that these are medicines. So what else can they be?
I think it's also precisely to your point that many of the people undertaking these treatments don't conceive of themselves as patients. There are other aspects of the professional healthcare relationship that may be missing. So my colleagues have talked about the clinical skills involved. The other thing that healthcare professionals bring is an understanding of the ethics, the importance of appropriate consenting. And consent is, if you don't understand the risks, if you don't know the consequences of what you're going into, then the treatment you receive is not properly informed. And I think it's really important that precisely because there are complications, precisely because there is a potential transition in the mind of the service user from being, as it were, a client to becoming a patient, that you can't wait for them to become a patient to go through a consent procedure. That's too late. So some of the wider behavioural ethical dimensions of healthcare professionalism there's real value in bringing those in earlier than is sometimes the case at present.
Just a final question about the knowledge of prescribing and ensuring that that is a role in providing safe, effective delivery. Hyaluronic acid is considered a medical device. It's not even considered a medication, like Botox is a medication. So, and there's a move to reclassify it from being a medical device as well. Is that something that, out of all of this, we need to think about? Like, what are medications versus what are considered devices, as in dermal fillers?
Absolutely, I would say, because a lot of the risks from the necrosis, vascular occlusion and stroke, death, all of these things come from the hyaluronic acid. So they are not necessarily, and when HIS clarified Regulation 12, which is part of the regulation where you have to have an appropriately trained professional in the building at all times, and they reclarified that with us a few years back. They said that that person needed to be there because of the immediate risk of the hyaluronic acid being injected. So with Botox, for example, if you inject Botox, it takes 2 weeks to take full effect. So you don't necessarily, unless there was an allergic reaction, you wouldn't necessarily have an immediate emergency with that particular drug. With the medical device, the hyaluronic acid, you have about 4 hours to dissolve the occlusion back out again. So there has to be a prescriber there to give access to that medicine to be able to do that. That you can't phone your prescriber and your prescriber's in Blackpool for the day. Do you know, your prescriber has to be present in the place for that medical emergency, because it would become a medical emergency for that person. I don't think it's appropriate to send the person to A&E, because, as you say, people are not all educated to the same level, and just being a doctor in A&E doesn't mean that you've got knowledge of how hyaluronic acid works. So that person would be best placed in one of our clinics that we deal with it every single day, and we deal with any complication. We know how to use the substances. So yeah, the people who deal with it, even the prescriber that gives the oversight, has to have knowledge and experience of the medicines and of the hyaluronic acid to be able to provide oversight, is my belief on it.
Thank you.
Brief supplementary from Patrick Harvey.
Thank you, Convener. Good morning. I was just curious, I was already thinking about this because of the term medical aesthetics that's come up several times, but in the discussion that you just had there about the idea that some of these procedures have been demedicalised, or that the term medical is kind of being contested here. Can I ask a bit of a basic question? What is it that determines whether a procedure is medical? What defines what are medical aesthetics as opposed to fairly obviously non-medical procedures that people might have for aesthetic reasons? Is it the qualifications? Is it the qualifications of the person conducting it? Is it the setting in which it's conducted, how it's regulated? Or is it whether it's being done for medical reasons, in other words, to treat a medically diagnosed condition?
It's a very good question. It depends what lens you're looking at it through, I suppose, in a way. Now, obviously, with Botox, it is a prescription-only medicine. So, obviously, that carries in itself some risks. You have to, by law, be seen by a face-to-face prescriber before you have any treatment done. So, I think that, in a way, carries some influence, as well as the risks, etc., that come, you know, and the indication for your treatment is a big factor. And it's one that we spend a lot of time, you know, making sure that when we are making our medical notes, and we follow a very medical model in the practice that I work in, we do speak to the patient about psychological impact of treatment, looking at their indication, full assessment, which is documented prior to treatment. I think, like you say, what makes it medical is probably the trickier thing, because you could look at it.
Not an objective definition. We're using this term medical aesthetics. Is there a clearly accepted definition of what that refers to and doesn't?
It depends what you look at. Yeah. So that particular drug, Botox, for example, can be used for cosmetic purposes, but it is a medicine. So if you're going to give a medicine or inject a medicine into anyone, would you prefer that I had done a medical consultation and took your history of medications that you're already taking in case there is an interaction with those two. So I know what you're saying. You're saying, well, why can a non-medical person not do this? Well, why can a non-medical person not give an enema? It comes down to that. Do you know? So we have to respect that these things are medicines and medical devices. So that is already in the name of what we are prescribing for the person. There has to be a person present to prescribe it, and it has to be a medical person.
But I mean, even within that answer, you're saying these things.
Yeah.
I mean, is there a clear definition of which things we are referring to as
Yeah,
medical?
There is from a VAT perspective, I think. So that's why I was saying what lens you're looking at it from. So I think from a VAT perspective, it's very clear. If there is no cosmetic indication whatsoever, it is classed as in if there's a medical diagnosis, it's medical. It's either purely medical or purely cosmetic. There's no grey in between area where it comes to VAT purposes. But I'm thinking from I can understand the way that you're phrasing it there in terms of from the how do we classify the difference between the two of them, but it would be, like Jackie said, down to clinical history taking, assessment of the patient, which I think is not done in a lot of practices. I think it is transactional. You go in, you say, I want 2 areas of Botox. The person says, lie down on the bed. A bit like a GP could say, I want some antibiotics. If someone walked into your GP practice, you would take a full clinical history before prescribing them those antibiotics. It becomes transactional if the patient comes in and has a demand on what they're wanting and the practitioner just says yes. And then
I appreciate that there are different perspectives on this. From a policy perspective, I'm not sure if I'm more confused or less confused, but thank you for the answers.
Thank you. Sorry, Stephen, we've got a lot to get through, so can we keep our answers concise, if you don't mind, so that we do actually get the information that we're looking for. Brian Whittle.
Thank you, Convener. Good morning to the panel. I'll ask a fairly straightforward question to start with. Do you think that minimum qualifications for procedures should be set on the face of the bill, or is that a place where secondary regulation would be preferred? I don't know if anybody's got an opinion on that.
It's unwise to get too specific on the face of the bill at that level of technical detail. Situations change, new treatments arrive, new procedures arrive. Getting too locked into primary legislation can unhelpfully distort practice. So I think just in that, it's got a very practical sense. It's better to have some of this in secondary.
Right with that, good. As we've discussed here, there's quite a mix here, given of so regulated professionals. There's well qualified but unregulated professionals, and then there's those or unregulated practitioners, and then there's those with minimal training. So how should the bill approach that regulation in a way that recognises sort of industry training? How do we pull all that together in the bill?
A minimum specified level, said that there needs to be an academic pathway offered for people going forward. I do think that is important. There is a course in development. It will be available by September next year. I think at the moment it will only be for healthcare professionals, and it will involve an element of theory and an element of practical sense as well, where you will get placement. So much like nurse training or being a doctor or being a dentist, you would do a certain amount of theory and then a certain amount of practical training. And I am aware that there is a level 7 that people talk about, but there is no transferable pointage, I suppose. If you look at it from an academic point of view, there's no transferable credits from that level 7 to university SVQF qualifications from that. So I think it needs to be standardised. I think the bill needs to look at it, whether that's in secondary legislation, then I'm not particularly sure. But I do think that there needs to be something addressed around about that. I do agree. There needs to be a set standard, because at the moment people will go on a 1 or 2 day course. There will be an element of Dunning-Kruger syndrome where they are told that they are qualified, so they believe that they are qualified. and they don't think they're doing any harm. But when we look at it from like a more qualified level, at university level qualified, and maybe master's level qualified, it doesn't seem that way to us. And they get confused because they think they are qualified, because they've been told that they are. So there is no academic set standard where people are taught to a level. So like for a doctor, for example, well, the doctor will be trained in a specific way, but it wouldn't matter what university that they went to, they would still be trained in that set standard. The same with a dentist or a nurse. And I don't think that that is there yet. I think that needs to be looked at, definitely, in the bill.
I think this is what the JCCP is trying to align its educational pathways to. So the consensus is that aesthetic medicine should fall under a form of advanced practice, and therefore should meet and attain certain set standards that the JCCP that I'm aware of has set out. They do have a number of approved educators. There is a university in South Wales that now offers the full master's level in aesthetic medicine, and I know that it is something that other universities are looking at bringing in because there is a call for it. So yes, an academic pathway in a speciality, for me, again, would align to an appropriate level of education for somebody moving into aesthetics.
So I have to ask the question then, how is currently is competence monitored, and how should it be monitored? How could it be monitored through this bill?
So there is, BAMAN is working on competency frameworks at the moment that they actually have worked quite closely with the RCN on. So there will be somebody, for example, you would go on the training course. You're not competent once you've done a one-day training course. You're trained, but you need to then have some supervision to get to a level of safety that's appropriate. So they have worked quite closely with other bodies on coming up with a competency framework specifically for aesthetics, but it would need to be some supervised practice after the training day, which obviously, at the moment, I think Jackie was saying earlier, there's some two-day training courses for non-medics to then be decided that they are competent. I'm not sure if they then do any, one-to-one after that. It's not clear because there's no frameworks in place at the moment. So what then qualifies, competency following on from that? So I think, yes, some competency frameworks that are specifically checked off, some supervised practice off the back of whatever training courses have been done has to be the level for any medical professional or anyone that's having training, because you need to then have some supervised practice after you've done your training courses. Because I think a lot of these, so I've got a background, I'm a nurse, and after 10 years of being a nurse into aesthetics, I did the aesthetic medicine postgraduate diploma, and I then did an MBA 10 years post being in business, and so I could understand the business side a bit more. But I think what they cover a lot in these training courses is more the business side, so they're actually losing out a lot on the clinical side, which is more important to understand first and foremost before then you have an understanding of marketing, business, etc. I think that's what's being skipped a bit. It's more focused on selling to the patient. And I don't think that's, appropriate really when you're first starting out and training, because then they're losing a bit of the clinical competence that needs to come first.
There is a course developed, as I said, from Caledonia Uni. It is a PGD and it is in aesthetics medicine. It will be at master's level. It will be launched in September next year, and it will have a practical element to it and an academic element to it. And I think, following on from what Amanda's saying, that's just absolutely essential, because you cannot just get theory on something and be academic on paper that you can do something. You have to be able to, these are hands-on treatments. So for example, in the NHS, if I was going to do a catheterisation, I would be shown how to do it by the nurse specialist that would show me how to do it, and then I would be supervised for, say, 10 treatments. But there would be a standard written for each different individual treatment that I would be offering. So that needs to be addressed. I think the bill needs to maybe specify, whether that's in secondary legislation, the nuts and bolts of it. But I think in the first, in the bill, it has to specify who can and cannot provide these treatments. Otherwise, we will just get people who have done a one-day or even an online course and got a CPD certificate continuing to treat patients. So it will just defeat the purpose.
I think there needs to be a clamp down on the training academies as well,
Yeah.
because I think they are a large part of the issue here. You know, I mean, there needs to be a real standard for the training premises and academies and practitioners that are actually teaching people how to do this. Because, I mean, you could train and do the 2-day course and then set up your own training academy a week later and be training others. And I think that's a real risk here, because there is a business element to it. And so, me personally, I think the training academies need quite strict and really thorough regulation, because then the people that are training and providing the training have got a high standard, and that will then be passed down onto, you know, whoever's receiving the training.
HIS has a role as well in this, I think.
Definitely.
What I'm hearing here is that there isn't ongoing competence monitoring. And we can't even define what a medical procedure is, and there's not ongoing competence. Wow. Convener.
Patrick Harvey.
Thank you, Convener. I was going to move on to some questions regarding fairness and equality. We've heard, both in the previous session and also in some of the written evidence, a range of views about equality impacts from the bill, including those who make the argument that many of the services, procedures that are available are being provided by a workforce that's predominantly women, predominantly independent. Many working class communities see this as something that's grounded and rooted in those communities. And also, on the other side, a concern that the equality impacts will extend to reduced availability, increased cost for these procedures, but also that many marginalised groups or groups affected by equalities issues are more at risk if safety standards are not high and are more targeted by the industry and more likely to be accessing these services. Can you give us an overview of your attitude to the equalities impacts? And it may be that they cut in both directions. Yeah.
That at the moment there is inequality anyway, because since 2016 nurses, doctors, healthcare professionals have been under regulation from HIS here in Scotland, and it's been a legal requirement that we have to be, and at the moment no one else is. So we are subject to fees, high standards, and we don't complain about this because we think that it's necessary for public safety. But why then, if we're looking at equality for people that are complaining now about it not being equal or fair and being on a fair business footing and offering treatments that are of less value to the consumer, why are we looking at that now and we didn't look at it when healthcare people were affected in 2016? So for 10 years almost, we have been under what the bill is proposing. So the bill's proposing oversight, it's proposing HIS regulation and fees. So we have paid those fees since 2016. So I think there's been a level of inequality all the way along until now. I welcome the bill. I think the bill needs to come into place. I do not want this bill not to be passed.
You'd say this creates more of a level playing field.
It creates more of a level playing field. I think some of these providers that are saying that they cannot then provide treatments at the low costs that they are providing them, I have been shocked sometimes at some of the costs, because you cannot even buy the medicine for the price of the cost that they are offering 3 areas of a toxin to someone, or, you know, they're buying, I suppose, unlicensed machines that they are using, you know, on consumers. And I think all of that needs to be brought into check. And I think through HIS and through the bill, this will be put onto a level playing field. I also think that I can talk a lot, as you can imagine, you're hearing that. But I also think that these are treatments, although we have had the discussion over medical, and if they're medical, if they're not, they are, without a doubt, they are, most of them are elective treatments. You're not going to die if you don't get it. So it's not like getting an asthma inhaler and you're going to have an asthma attack and die. You're not going to die if you don't get this treatment. So if it's an elective treatment, why are we looking at this, if you know what I mean, cost? Because the cost of the treatment, you would only get a treatment if you could afford it, if that makes sense.
If we go back, so it's inherent in regulation that you're cutting some things out, because if you weren't restricting the field of what is provided, you wouldn't need regulation. What regulation does, in a sense, is draw a boundary and say that some things are outside that boundary. So it is the premise of the bill that by adding procedures to regulation in the way we've been discussing, that will mean that some current providers will struggle to meet its requirements, or if they do are able to meet its requirements, it may be at greater cost to them and to the people they treat. So I think you can't. There's no approach to this that doesn't, in some sense, address the inequalities in both the directions that were in your question. As always, it's a question of trade-off between the costs and benefits to the different parties. I don't think there's an absolute line that comes through from these provisions.
Just to go, I know this isn't on this, but back to your point on medical procedures, there is actually an ECJ ruling on what quantifies medical procedures. It just came into my head after we were discussing the point. So it's the assessment and the diagnosis part is a really big aspect of, you know, what comes into a medical procedure, your diagnosis and your justification for treatment, and then obviously the psychological impact on the patient. So hence why a lot of bodies at the moment that represent nurses, doctors, dentists are looking at psychological impact on patient well-being and, you know, what is improved off the back of treatment. But as Jackie said, on your point now, these are elective procedures. You know, they are kind of more of a luxury procedure that people are coming in for. They don't necessarily, you know, drastically need them. They're not, you know, life-altering procedures. But I think it has to go back to the safety and, you know, any, you know, equalities to access. Really, the safety for the patients has to come first and foremost, you know, in whatever we're doing.
Mm-hmm. Anything to add?
I concur with the panel.
Okay.
Yeah.
I mean, the last point then on this is about, I mean, what's sometimes described as the balance between patient safety and accessibility or affordability. And from what you're saying, I get the sense that the whole panel is saying patient safety has to be the priority. Is there any merit in the counter-argument that says that if we reduce accessibility of procedures for which there is a commercial demand, or we increase the cost by regulation, that will drive some people to access the same procedures completely outside the scope of regulation in a much more unsafe and you know, not at all professionally delivered setting? Is there any potential argument that the impact could be negative in that way?
Patrick, it's already happening.
Mm-hmm.
It's already there. So I don't think the bill will make it worse. I think it can only make it better. So I do not think that by putting the bill in place, it will force anyone else to do anything illegal. I think there already is that going on. We've seen videos in social media of people being injected or given treatments in the backs of taxis, in the backs of sheds, and it's horrific as a healthcare professional to watch these things being done. So that will continue until, but I think it will further enhance the safety because there will now be a law that states that you cannot do that. But at the moment, there is no law to say that that cannot happen. So I think it would go the opposite way, Patrick. I think it would stop a lot of it from happening. I think people would be more afraid of it. One part of the bill that I don't think we've covered is just, and you may be covering it somewhere else, is like the summary charge and the summary conviction. So it carries a fine and it carries a summary conviction to it, but the summary conviction is not a recordable summary conviction. And oh, sorry,
enforcement
yeah.
compliance. So I don't want to step on
yeah,
their
but
toes.
so
but
to answer your
I'm getting a
question, no,
fairly
it won't
clear
make it. It won't make
sense.
it worse. I don't
Okay.
think.
Thank you.
No.
Thank you, Camina.
Emma Harper.
Just, you've kind of answered the question already, Jacqueline, about we've heard about, and I've seen on YouTube videos, fizz and filler parties where people are drinking alcohol, which really you shouldn't consume alcohol under any procedure at all. So do you think this will help address that and actually probably reduce the ability to have fizz and filler parties?
Yes, I totally agree that there is no law in place at the moment to stop any of that from happening. So I think that when people realise that they are breaking a law, if there is a law in place, then yes, absolutely, it will reduce it. Yeah, 100%.
And like Jackie said, it comes on the what then happens to the practitioner afterwards, i.e. what the fine. I know because there's been discussions around a fine, or there's been, but I think it needs to be enforceable enough that they feel a consequence almost, because like you say, otherwise, fizz and filler parties, if it's just a little slap on the wrist and a £200 fine, then it may just continue. So I think it has to be enough that it's off-putting, if that makes sense. Yeah. To whoever would be looking to do it.
Got someone that's earning, say, over £100,000, like in a clinic setting, or I'll use the term clinic setting very loosely because some of these places are not really defined as clinical settings. But if someone's making that amount of money, then, and if the maximum fine is £5,000 that can be imposed, if it's not £5,000, say it's £1,000 for talking sake. And that's just going to be if it doesn't carry any kind of other penalty along with it. So I know there's a summary charge that goes along with it, but the summary charge is not a recordable summary charge. So what's to stop the person treating it like an expensive parking fine? They will just continue and continue and continue. And we will get some people that will flout the law and continue to do that. We've seen it with some clinics who have got into trouble with advertising standard agencies. There's a specific clinic. Oh, sorry.
Stick to the specific question.
Yeah. So yes. So I do. That's what I think about it. Yeah.
Okay. Thanks.
Thank you. So I suppose we touched on this a bit throughout the morning, and certainly touched on it last week with the panels that we had about gathering data, reporting mechanisms. So I suppose I'm keen to hear your views on a centralised adverse event reporting system, a national register, standardised training requirements. Again, we've sort of touched on a bit on that, and data and complications. So do you think that those are needed, and who should administer that?
Like I say, I spent a lot of time trying to gather some data ahead of the meeting because it's always good to have some numbers and something quantifiable, isn't it? At the moment, SaveFace and JCCP do gather some stats. I know they do, but there isn't really a centralised reporting mechanism to actually gather the facts and the data. So, like I say, off looking at those, I could see there was about 3,000 complications across the UK. There wasn't anything specific for Scotland, but I could then work it out based off the Scottish population, roughly how many were quantifiable for here. So I could do a rough, analysis on then, there's roughly around 700 complications are then equatable to Scotland. And then you could work out a bit of a cost to the NHS as well. But I think at the moment there isn't somewhere specifically that people would go to. And I know practitioners have spent a lot of time trying to gather the data from A&E, and the difficulty is because there's not an ICD code, A&E doesn't know how to categorise an aesthetic complication. So therefore, when you then go in to look and see the audits or anything else, like you can't actually find what you need to. So it's probably a bigger problem than what I'm actually sat here quoting to you, because it's not written anywhere. But I would absolutely support a reporting system that was, national and that was, you know, Scotland based as well, just so that we could really see the numbers.
So who should gather that data?
I think there is a mechanism via HIS to do that.
So.
So it's really difficult for the
Health
official
Improvement
report
Scotland,
to record accurately if you speak over each other.
Yes, I think Health Improvement Scotland would be a good place to go to, just because all clinics, if they are going to be registered with HIS, those reports could go back, because you're talking about there could be a whole range of complications from an injectable medicine, an injectable device, because we've got fillers which fall under injectable devices, we've got Hylays that falls under injectable devices, CO2 lasers. I think if it was all in one place and it's not going off to be reported, because obviously you would report back to the manufacturer if there was any issues based off whatever you were using, but at the same time it's not going centrally anywhere. So there's about 10 different brands of Botox, filler, etc. The data's going back to, you know, yellow card system potentially back to the manufacturer, but then it's not collated, if that makes sense. It's not anywhere.
Practitioners use the yellow card system. Would all practitioners report back to manufacturers if there was complications with this?
Yeah, they should. Yeah.
Okay, and so I suppose we've spoken about some practitioners who have perhaps not had the level of training that the panels had on these. So you're assured that they would report that back?
I think a non-medical professional wouldn't even know what a yellow card system is, because it's something you kind of learn as part of your training. I don't think necessarily they would think to do that. I think they would be unaware that the system's in place. So I think yellow card systems are good for reporting back, but I think, like you say, a more centralised way, and Jackie, I think, has got another point there, but I think a more centralised way would be better, personally, I think.
Sorry, Amanda. I was going to say that if we are talking about the legislation and we are talking the legislation's passed, everyone's in an HIS regulated clinic. We have a duty at the moment, if we have a complication, to go onto the notification portal with HIS and report that. So that would be a way of recording.
I appreciate that, but I suppose I'm looking at how things are currently, that we don't necessarily have a complete picture.
No, we don't. We don't. It's anecdotal evidence that we've got at the moment. And I think it comes down to the World Health Organisation codes, like the ICD-11 codes, and being recorded in A&E, being unable to extract that data, and also because there's other developed countries don't have non-medical injectors, that is all medical people, and medical people have got what we call a duty of candour. So we have got to, as a profession, acknowledge if we've done something wrong, and acknowledge and you know, admit to that and apologise to the patient. So I think there's a lot of that in there. So yes, I absolutely agree there needs to be a centralisation of this.
And in terms of public awareness of the proposed changes, so should this bill become law, do you think there should be mandatory information for consumers as a part of the bill to make sure that it works, and so that the public understand what they're consenting to when they go to a clinic for Botox filler or what chemical peel or whatever? Yeah,
I really think Scotland's kind of leading the way here. I think the public support would be very much the public would be very much in support of the bill. Just from, you know, we've got quite a large practice, and just speaking to patients, a lot of them value safety, and a lot of them come into our practice in particular because they value safety. And I think all the Scottish Government is doing here is supporting public safety. So I think, yeah, definitely more information for consumers who might not have been in for treatment before is always of benefit. I think just educating the public as much as we can is always in their best interests.
May not be aware of a risk currently when they're engaging in.
Absolutely.
If they don't. Sorry. Can we just have one person speaking at a time? As I say, it's difficult for OR to record accurately if several people are speaking. Okay, sorry, Remy, you wanted to...
Just going to say that if they don't have an awareness of the risk, those are the ones that don't see themselves as patients either. And it's the public, it's that public education, it's that public awareness of, you know, the risks that come with the process and the treatment. So absolutely, there does need to be a lot more done in terms of public education and awareness around the risk association, around who they're going to see, what the procedures might involve, what the consent process will look like, you know, periods for cooling off, which I suspect don't occur either, you know, where they're able to obtain all of the information that they need to weigh it up and make a reasoned judgment as to whether or not they want to proceed. I expect that that doesn't occur in many practices if they haven't got a healthcare professional there that's enforcing that. Likewise, with the subsequent reporting of any complication, we are reliant on that practitioner really to provide that information to a centralised government, a yellow card system, you know, and the honesty of that practitioner and the duty of candour of that practitioner to do that in order to ascertain that data.
Thank you. Elena Bitton.
Good morning to yourselves. We've already touched on this a little bit this morning. I want to spend some time speaking about enforcement and compliance. So to kick it off, to what extent are the offences as set out in the bill, so if we think about things providing procedures out with permitted premises or to under 18s or obstructing his investigations, are they clear and appropriate? And are the proposed penalties, we've already discussed that, fines up to £5,000, sufficient to deter unsafe practice? Or is there anything else we should be considering? And should there be sanctions for repeat offenders? So I don't know if, Jacqueline, if you want to start, because you'd already started to discuss this.
There should be sanctions for repeat offenders. I welcome the bill. I am so happy that the bill is here. I'm happy to be here today, even discussing it. And I feel privileged to be able to do it on behalf of the group that I represent. I do think that it needs to go slightly further. I think repeat offences, you could just continue to flout the bill. It would be kind of treated like, I don't want it to be treated like it's just an expensive parking fine, and that you would be fined and then fined again and fined again. We've seen it with ASA and ASA imposing fines on certain clinics that continue to advertise cheap deals or keep advertising like a prescription-only medicine. We've seen several times a certain clinic group has been fined and fined and fined and fined again, and it costs less for them to pay the fine than it does for them making the money off the advertising campaign. So there has to be sanctions. It needs to be a little bit, I kind of likened it in my head a little bit like the COVID fines that happened. There was like one fine and then it kind of got a little bit more and then it became a kind of more serious kind of offence. So I do think there needs to be something recordable, because harms can be brought to people because of these treatments, you know, burns. And to be fair, if they've not been consented properly and they don't know the risks, like what the last person was talking about, then is it really like a grievous bodily harm that you're doing to somebody? You know, even if the practitioner doesn't really understand the full implications of it. So absolutely needs to be looked at and more robust, I think, from that point of view.
Would the rest of the panel agree with, you know, the need for perhaps some type of ladder of escalation? So, and depending on what the level of the breach would be and what level of severity that possibly could be. Stefan, I saw you wanted to come in.
Yeah, just to make the point that you can only talk about sanctions in relation to somebody that you've detected. So actually it's the investigation and detection of this that can be more troubling. In the world of dental regulation, we have this already, that tooth whitening is a protected activity. It is widespread that it is done illegally by some of the same people in some of the same settings that we're discussing about here. Now, that's not in the scope of this bill, and I mention it solely that actually tracking that down, taking through cases, is not a straightforward. So I think it's worth considering how it is that these cases surface and what is the route that brings them into then whatever form of sanctions is ultimately decided on.
That's quite helpful, because that was one of the questions I had, was round about the resourcing of you know, the inspection regime that would need to be carried out. Do you foresee that as being an issue? How would we actually ensure that HIS were adequately resourced and empowered to be able to deliver what the bill is intending?
So I think you've got to distinguish between the premises that in this scenario HIS would be inspecting. So kind of by definition, they are likely to be doing legal things in legal ways. It's the people outside the system who therefore would be subject in terms of the bill to the HIS power of entry. but wouldn't otherwise be directly inspected. So fundamentally, there's a choice. You either wait for cases to arise, people to report concerns, or you have some form of investigation, you go out looking for cases. And both models can work. A lot of local authority work happens on the go and look basis. In this kind of area, it depends much more on reporting. So if you want to be confident that there is a very high probability of what would have become illegal practice being detected, you probably need somebody, and it might be his, or some of this might work at local authority level, to have the resources and the remit to go and look for it. If you're willing to be responsive and address cases as they arise, that's a cheaper system to operate.
Do you foresee there being any unintended consequences coming out of the bill? So if we do think about, and this was touched on last week, and it alludes to the questioning that Patrick Harvey had round about that equality of access and that fairness, where we might see some practices being driven slightly underground a little bit, where people are going to be able to access services out with licensed premises, which is obviously going to prove to be the trickiest part of the system to detect. How can we ensure that that is thought about when we're looking at this bill?
I think in the end, it's a balance of risk. So the benefit from bringing most of this activity into regulation, those who want to comply, most people do want to comply. It is not that some don't, but on the whole, people don't want to break the law and do want to be compliant if they have a system to be compliant with. And what this bill will introduce is that system to be compliant with. So the benefit from doing that is very large. There is a cost, which, as you say, is it may drive some people further away from good practice, but as already been mentioned, in the absence of any statutory control at the present in Scotland, anybody could be doing anything anyway. So in that sense, they're not necessarily they're not driven to doing things differently from what they're doing now, and therefore there's no greater risk. It's just that what they were doing would become illegal, having not been illegal in the past.
And do you think that the provisions and offences in the bill are suitably clear to enable compliance? Because that's something that we started to uncover already, that perhaps it's not really clear how you would actually comply with the measures set out under the bill. I don't know if, Amanda, you look like you're maybe wanting to say something.
There has to be some accountability if you're practising in this area, to be familiar with whatever standards are set out as part of, the regulatory compliance, because I think the accountability really is on, the professional delivering the service, that they actually have a good understanding. So I think anyone can turn around and say, oh no, I didn't really understand, I didn't really appreciate what the changes were. But I think if it's there and it's clear and it's easy to access, then, like I say, the accountability needs to be on the individuals offering these services, that they are familiar with where the line is drawn, around what they can and can't do. So I would say, the accountability has to be on people delivering the service to fully understand what is within the law and what is without the law. I think for a lot of people, like you say, nothing's going to change. This is just, Scotland really kind of leading the way in terms of regulation. And for me, regulation only means better standards. That's all that can come off the back of more regulation, is a better standard across the board and consequences for those that don't follow that good standard. So I can only see positive coming from these regulatory changes.
Okay, and maybe, Jacqueline, just to kind of explore the concerns you had round about a summary conviction and, and that not being recordable. I don't know if you want to speak to perhaps whether you see that the top level of what conviction could be applied here is maybe not strong enough.
Yeah, I think because it's not, because the summary charge is not a recordable summary charge, and I understand that there would be legal implications and legal costs with that, but we can't have a law that then you don't actually enforce, or it doesn't, it's just fines. I think back in 2016 we were told that if we didn't HIS register, we would get a £3,000 fine, we would get reported to the Procurator Fiscal, and we would potentially then have a criminal charge. And as a nurse or a medical professional, you can't have that, you would get struck off your register. So there was a fear factor sort of fed into us that if we didn't do it, we would. But to date, nothing. There has been no convictions, and there are still people who are healthcare professionals who are flouting that particular law. So I think if we're going to do it, and I, like Amanda, I can only see that this will improve things, this legislation going through, and it will improve patient safety and the standards. So I can only see that we can't allow this to fail. So it has to be a tangible, recordable charge if someone's going to repeat offend and just continue to do it. And will the Procurator Fiscal take it seriously? I think they will only take it seriously if there is a recordable summary conviction. So, for example, if someone, if a drunk person was caught doing the toilet in the street, they would have a recordable offence, like from a summary charge, put onto like their record. But if someone can inject someone and cause a stroke or potentially death on that person, why is that not then recorded? Was my thoughts on it when I read through and dug into it. So I feel that the harm that you can do is great enough to carry a proportionate, tiered approach to it. But I think it would be proportionate that for repeat offenders it would have to be recordable.
Okay, thank you. I don't know if anybody else in the panel wants to say anything else before I hand back to the convener on this.
I think it's important not to undermine, you know, the professionalism that we're striving for here. And I think by not having any enforceable convictions on those repeat offenders, we do undermine that process. So we do need to have a fair but structured escalation for those repeat offenders, so that if we are accidentally missing somebody that has maybe not understood, has perhaps misinterpreted the legislation, they have an opportunity to learn and improve, you know, but anything subsequent to that, then, you know, we need to think about the patient being at the primary focus and that patient harm potential.
Thanks. And just to come back to you, Stefan, because I've just thought about it, in terms of when you were speaking about at a local authority level, in terms of the licensing that's going to go round about this, do you feel as if there's a role there for the local authority to work in partnership with Healthcare Improvement Scotland to ensure that we've got licensed individuals, licensed premises complying within the system as set out in the bill?
I'm probably not close enough to the detail of how it operates to have a strong view on that. I think precisely because local authorities will be involved in the level 1 licensing, that's where the blurs and the overlaps are most likely to occur. So it seems likely that they are going to be better placed to be the kind of first line of detection than HIS will be.
It's very helpful. Yeah.
Just quickly, the lasers obviously come under environmental health at the moment, so some practices do have some quite advanced lasers, like CO2 lasers for example, can cause quite significant harm. I think that might prove a little bit tricky because they're falling under a different category, I think, so that should be okay. But I think sometimes with lasers there is the potential for, you know, some quite permanent damage off the back of the laser being. So that might prove quite tricky for the councils to manage. But at the moment, if something goes wrong with the laser, it's reported to environmental health. So it would need to be that either changed or stayed in place, and there was just a clear reporting process off the back of any changes that do come.
That's helpful. Thank you.
Joe Fitzpatrick.
Thanks very much, Convener. Part of the written evidence we received, we got some, I thought, very powerful evidence from Advice Direct Scotland. It's powerful because of the case studies that were there, and including teenagers as young as 15 being at the end of botched procedures that I think got a bit of coverage in the media yesterday, no doubt you've seen. So I guess that brings us back to a discussion we had last week when Sandesh Gohani particularly was leading a discussion around whether 18 was the correct age. So keen to hear your thoughts on that, but also whether you feel you have the tools to enforce 18 if that is the correct age. 18 is the age that young people can start buying alcohol, but in a number of supermarkets it's so difficult to identify if someone's 15 or 18 in so many cases that they have a challenge 21, for instance, in many cases. So whether you think that is the right age, and how you would make sure that it is enforced would be good to hear.
So at the moment, like if you take anyone to like a tattoo place or a piercing establishment to get them established. There's a place near to where I am, and when they go in, they check the person's passport. I actually watched them turn someone away because a young boy had taken his brother in and said, "Oh, my dad said it's okay," and they were like, "No, we need evidence of your age and a parent with you." So I do think that when you're talking about that medical process of taking the person's name, doing all the details from that person, taking their address, basic information, and then all their medical history, I think there's less chance of not knowing what the person's age is, and you can ask for a passport. So as you make the appointment, you can say, "Can you bring a passport?" or some sort of form of identification to let yourself know. That said, most of the patients, and I don't know if I'm speaking just for my particular clinic, but most of my patients are aged from 25 years and older. And to my clinic, I rarely see anyone of that younger age group. Would I be doing some of the procedures to someone under that age group? Probably not. So I think as a healthcare professional, I'd be more likely to say no to someone who's younger anyway. But yeah, there is mechanisms where you can check the person's age. There's always going to be, fake ID. There's always going to be all of that. But if you're seen as being proactive in trying to establish what the person's age group is, I do agree that it needs to be from 18 years and older. And we've been under, as I said, those regulations since 2016.
Yeah. Amanda, you're...
Yes, no, so I would agree with Jackie. I mean, it's not really the typical representation of what we see, given a lot of what we offer is, more anti-aging type treatments. I would struggle to justify giving an 18-year-old treatment for something like that, when they're in a position where I don't feel it's a clinical justifiable treatment for them. So there would be the element of saying no. My worry is that some people would maybe not take that viewpoint and would just think, right, there's some money on the table here. This young person's come in, they want this doing, I'm just going to give it to them. And so I would question the justification of treating 18-year-olds, on the whole. But I think there has to be a level somewhere. So I can see, from a consent perspective, absolutely, they likely have understanding of treatment procedures at that age. It's just the kind of the sector that we're in is questionable as to whether it would be a clinically justified treatment to give. But I mean, then there is other things. There's skincare, there's microneedling, there's other things that give skin health benefit that you may, feel are appropriate for that patient. But we don't tend to see many coming into the practice that I work in anyway.
Rather than...
I think my personal preference would be yes. I mean, it could, because I don't feel that, younger than that. I can't see why you'd be able to clinically justify a treatment. We certainly don't have 18-year-olds who present.
Stefan or Remy? Stefan?
I think we've got to be careful distinguishing between what might be clinically appropriate for somebody and the level at which they are capable of offering informed consent and understanding the risks and benefits. So I think 18 feels like the right place for informed consent. It might well be that there are treatments that are wholly inappropriate to 18-year-olds. I think that's a different issue. I think it is also important, though, that in a very small number of cases, there may be medical justification for treatment for somebody who is under 18. So it's important that that isn't an absolute bar, but there would need to be specific medically prescribed reasons for treating somebody younger than 18.
Okay, thanks. Remy?
Yeah, I tend to see two avenues when it comes to assessment for patients when they come in. One is a beautification treatment, and I think this is the treatments that we're talking about where we potentially may see the younger age group who are influenced by social media. And like my colleagues here, I see very few of those people, and I think that's just because of the message that I portray in terms of my ethics. And then we have patients that are looking for rejuvenative treatments, or age-defying treatments. And I think it very much depends on what the patient is coming and looking for. So if they're looking for something like a microneedling treatment or a skin treatment for acne or something like that, then absolutely that there's a scope there to be able to manage that patient. And it comes down to your clinical assessment and your ability to assess the driver behind why they are seeking those medical treatments. Is it because they are you know, we want to screen for something like a body dysmorphia. You know, are we looking at what they're actually seeking, being a potential mental health condition, or is it not? And that's I think, where the clinical assessment becomes really pertinent, and the ability to deep dive, have an ability to form trust with the patient coming in, so that they are able to really be honest and open about what their drivers are for seeking that treatment in the first place. So, yeah, that's important.
The concerns are things like fillers, where people are looking at using their social media to say, this is what my lips should look like, for instance, and that's the driving force. So it's not a health issue, it's absolutely based on what the social media is telling them that their face should look like.
Would indicate somebody seeking a treatment, a beautification treatment. So they have seen something on a social media post, you know, a celebrity with a certain look and style, and they want to emulate that. But is that because they have low self-esteem, because they have low self-worth, because they have low self-confidence? Do they fully understand, you know, the consequences potentially of embarking on medical treatments, and then the potential that, you know, something could go wrong, but also there's the risk of that fade of acknowledging every time you're having a treatment that what you're looking at in the mirror is representative of how you look. So it can escalate quite quickly with things like body dysmorphia, you know, and they seek more and more and more treatment because they are trying to emulate something. But that, to me, is a mental health condition, potentially. And that's where we need to be really, you know, scrutinising the drivers behind what the patients are seeking.
And I think back to the point, taking it up to a 21, very briefly, taking it up to a 21-year-old patient might become quite tricky for those that are in for other things such as acne treatment or, you know, other things that are falling under the breadth of the umbrella. But I completely agree with you from a dermal filler type. I agree with what my colleagues are saying from a dermal filler type perspective. It's not that patient coming in for beautification that could fall into the trap of having treatment where it's not necessarily needed.
Okay, thank you very much.
Thank you. Can I thank the panel for their evidence this morning? And I'm going to briefly suspend so we can change witnesses. We'll continue agenda item 2 by taking evidence from a panel of witnesses on the non-surgical procedures and functions of Medical Reviewers Scotland Bill. Our second panel comprises representatives of regulators, enforcers and inspectors. And I welcome to the panel Laura Boyce, Chief Inspector of Regulation, and Eddie Docherty, Director of Quality Assurance and Regulation, both from Health Improvement Scotland. Brett Collins, Director of Safe Face, who joins us online. And Paula McLaren, Senior Advanced Practice Advisor, Nursing and Midwifery Council. And we will move straight to questions. I'll kick off this session. So I'm keen to hear to what extent you think the bill provides suitably clear definitions for procedures and practitioner roles to enable consistent enforcement. And if not, what specific areas need clarification? If you'd like to start.
Yeah, certainly. Morning everyone, thank you for having us today. So from a Healthcare Improvement Scotland perspective, I think most of the bill is clear in principle. There are some of the definitions and points of clarity that we know that were intended in the original consultation, particularly around the training, the supervision and the delegation sort of criteria that would really be useful for us to clarify what that would be, because I think for us to be able to regulate with a level of consistency, being able to specify what the terms around training, delegation, supervision and the expected standards would be helpful. Now I understand that in terms of the UK internal market that has been the rationale for not having it within the proposal of this phase of the bill, but potentially within secondary legislation. So we would very much support those being clarified. It would definitely be an element that we think could give us potential challenges with operationally implementing. I think the other aspect of it, in terms of the definition, is from a permitted premises, it very much appears that the intention is for it to be run from a fixed premise in order to control some of the healthcare environment and the standards pertaining to that. Now, obviously, we also regulate independent medical agencies as well as independent clinics within the definition at Healthcare Improvement Scotland, and there are some examples where an independent medical agency could result in the provision of a non-surgical procedure. And so I think from the point of clarity that if it is expected that they are only from the permitted premises of an independent clinic, we would seek to clarify the role of an independent medical agency. I can give you an example of that if it's helpful.
I'm a wee bit confused, Laura, because you started off by saying you thought it was clear, that there was lots of clarification in there, but you've just cited a lot of areas where you would like to see more clarification.
Yeah, I mean, I think fundamentally we agree with what's provided. It's just small points of note, I think, for consistency. The training delegation we are understood as one of the powers for ministers to outline in phase 2. So I'm saying we would like to see that drawn out within the secondary legislation of the bill, and we're saying we would support that approach because we think we need it. The bit about the IMA is just conversational, that because it's a newly enforced area from June of this year, it's still quite new for people, and so again we think just for that point of clarity and consistency it would be worth is it specifically fixed premises from an independent clinic. So that's really the rationale of those two aspects.
In a minute, Eddie, I suppose I'm really keen to explore this, because what you're saying there are small points of clarification. To me are big issues of law in this bill potentially. Who's delegating, who's supervising, what training's required. I would see those as being really fundamental things in terms of the regulation of the procedures that we're talking about. Eddie, did you want to address that?
If you wouldn't mind. I think in its broadest sense, the clarity in the bill is exceptionally helpful and really moves things forward. The points Laura have made are areas that have been of concern for a while, particularly around that competence and capability of an individual. With the magic wand, we would clearly like that more defined. However, with that piece about it being registered professionals in the main and that delegated authority, there are clear guidelines for that. But for specific technical skills, there is a view that it's always more helpful if those are clear, concise and can be followed universally. Hope that's helpful.
Kind of. I'm still seeing that there's lots of areas of clarification that need to be teased out or established for the bill to fundamentally do what it sets out to do. In terms of the procedures that the bill covers, do you see those as being clearly defined?
With what's been proposed from the Group 1 as the local authority licence and the Group 2 and 3 as they were laid out, we think within the permitted premises to be regulated by HIS, we are content.
Okay. Anyone else want to come in at this point?
Yeah, so we're obviously the Nursing Midwifery Council is the independent regulator statutory body for nurses and midwives across the UK. So I think your question was specifically around definitions and clarity. And as an independent professional regulator, we don't have a position on the risk groups or criteria, but we are broadly supportive of the approach to developing consistency both for professionals and for members of the public. So as a clinician myself and a registrant, anything that adds that clarity and reduces that inconsistency will help to mitigate some of the risks that have been identified within the bill. We would like clarity on how the criteria will be developed, how often they'll be reviewed and by who.
So do the panel think that the bill is clear enough on what constitutes supervision or management by a healthcare professional? That might be something for you, Paula, given that you're here as as NMC representative.
Yeah, so in terms of supervision and delegation, we are clear through our standards set out in our code of the requirements around professionals and that includes all professionals, including those who are working in non-surgical cosmetic prescribing. So there are requirements around supervision, around having the appropriate knowledge, skills, competence, capability to deliver those procedures. We've updated our position in June of this year on remote prescribing. Yeah.
You back, so I'm not asking about the NMC's codes or your policies and procedures. I'm asking about the bill. Is the bill clear enough in terms of what constitutes supervision or management by a healthcare professional?
Yeah, so I think the bill could be clearer around expectations around supervision, which we would then ensure, we'll hope it would align with our own position on supervision.
Needs to be clarified, what needs to be added to the bill in order to satisfy NMC's codes?
So I think it is just around being really clear on who can supervise in these situations. I think it is about training and competence and making sure that professionals are able to supervise. So not everyone who's a non-medical prescriber will be suitably qualified to work in or supervise professionals in this area of practice. So it's that real clarity around prescribing and around who is able to supervise individuals carrying out these procedures.
So would you expect there to be additional training for those registrants?
So again, under our code, we would expect that individuals and practitioners undertook additional training to be able to carry out those procedures. So I think we need to be clear that this isn't just about prescribing. As I said, this is about the totality of non-surgical cosmetic procedures. Our code, as I said, sets out our expectations around additional training, and individuals have to demonstrate that they remain competent and capable in their scope of practice and roles, and that would include ensuring that they're having ongoing professional development and appropriate education and training.
Okay, thanks. And I should put on record that I'm registered with the NMC. Brett Collins.
I think from our position, and we included this within our written response to the consultations, I think in terms of the clarification, whilst, supervision, delegation, training, etc., might be only small words, they're a massive piece of work, in my opinion. And quite a bit of work does need to be done in providing more clarification. I think especially around the word supervision, delegation. This is also a ever-evolving sector, new treatments, new ways of delivering treatments. And, currently, to my understanding, within the HIS setup, there's no mandated qualifications for things like cosmetic surgery, which is a much higher risk, in principle, set of procedures. So I think there must be more clarification around exactly what that looks like and the pathway where that doesn't currently exist.
Okay, thank you. Just moving on a little bit, so how can the legislation ensure that procedures cannot be misclassified into lower risk categories as a means of avoiding stricter compliance requirements, and what mechanisms would prevent that? Eddie? The microphones will be operated for you.
Okay, thank you. Sorry about that. So we believe there is quite clear guidelines and clarity within the bill about what those actual procedures are and how they will work, and we've been very supportive of that level of clarity. There is always an ability to kind of have workarounds in these systems. However, I think the overwhelming response is it is a much safer approach, and the definitions are exceptionally helpful moving that forward. And as we move forward, Healthcare Improvement Scotland would take a clear view on how we interpret that and indeed how we then enforce it should there be any issues.
Laura, did you want to add anything to that?
No, I would be content.
And so my final question is really about verification of minimum training standards, which again would fall under HIS's remit, training and qualification standards for practitioners. So how feasible would it be under a different approach for enforcement and for monitoring of those, making sure that they're complied with?
So part of this would always go back to the professional registration of the individuals, but from a Healthcare Improvement Scotland piece, we would look for clear indications of competence and capabilities along their professional guidelines, and that they actually map across to the delivery of care being identified. A standard approach would be incredibly helpful. So we establish a baseline for what competence and capability looks like, both academically and clinically. However, the professional standards give us enough to work from just now. However, it will be a grey area until we actually get full clarity or have been through a full process on this.
That would be for healthcare professionals?
Yes.
What about other practitioners within a setting where they're supervised by healthcare professionals? So people who are perhaps not registered nurses or doctors, but are other...
And I think it comes back to that delegated function of all registered professionals and how they then exercise that, and we would expect that to be clear, concise and be available for us whenever we do any form of inspection or we have any concerns with it. But Laura may have some points she wishes to add.
Yeah, so happy to build on that. I mean, from an operational perspective, when a service is registering for the services that you provide or the procedures you provide, we would expect sort of almost like standard operating procedures of how informed consent would be obtained, what the standards are expected of that clinician, how it's articulated to the service user themselves, what those record-keeping standards are, and they would be applicable to anyone working within the service. At the moment, we're not sure and are not able to quantify really how many providers that are non-healthcare professionals will be able to align themselves with a healthcare professional to meet the definition of a permitted premise under Healthcare Improvement Scotland regulation. So I think at the moment we are working on the premise that the vast majority, and there will be no change for those who are already registered with us, of the standards that we expect in terms of that ethical information sharing and informed decision making with the service users that engage with them. So they're just sort of standard processes around the registration of a service. Again, when we inspect a service, we would look at aspects of the record keeping of what was the interactions with the service user to come to, what was the most appropriate treatments, was the treatments undertaken or was it declined following consultation. So they're kind of standard processes for us, and we don't really foresee any change to that process. The bit that probably is unanswered is your question of I'm unclear how many non-healthcare professionals will be able to align themselves to a healthcare professional for the prescriber aspect, and it's also broader than just the prescribing of the procedure. It's about any adverse events or any sort of complications that arise to it. So as our regulations stand at the moment, we would already prescribe for non-surgical procedures that the individuals must be over 18 and that you must have a prescriber on the premises. So again, the bill is largely in keeping with how we operationally function at the moment.
Sanjesh Gohani.
Thank you. Declaration of interest of practicing NHS GP. We're going to come on to the regulation of workforce, so I just want to keep this question very tight. The content of a medical degree is regulated by the GMC, and coming on to the question that was asked by the convener, so who should set the educational standards, the curriculum approval, the quality assurance, the training oversight for people who are going to be aesthetic practitioners and trained to be regulated as such?
So yeah, I'm happy to start that off. So in terms of education and training, working in the aesthetics field, and as an independent regulator, we don't feel it's appropriate for us to set education and training standards. We feel that is a role for government, but we would ensure that professionals on our register working in this field uphold the legislation of the country that they're working. For us, this
if not you, then who?
So we feel this is a matter for government to set the education and training standards. We set education and training standards for certain post-registration qualifications. That includes independent prescribing, but our code refers to continuing professional development. So this would fall in the realms of kind of, continuing professional development and ensuring that individuals undertaking non-surgical cosmetic procedures had the relevant education and training, whatever that might look like. I think if government were to set some parameters around education and training and bring in regulation, as is suggested in the bill, it would bring clarity, and it would ensure that professionals are reaching and maintaining a certain standard. We could then ask for them within Scotland to demonstrate that capability, ongoing professional development through our revalidation processes, which are currently every 3 years.
So there are currently SG accredited programmes for this. I don't think there's a definitive answer here. However, if we look at other competence structures, then commonly a cross-professional group linking in with their regulators, and the regulators in this broader sense tends to work most effectively. The skill being delivered to a patient should be consistent whether it's a doctor, nurse, midwife. So a cross-professional group has been seen to work pretty effectively with support from colleagues in SG, and indeed we would be happy to take a view to support that, but could not confirm it.
Thank you.
Elena Whittam.
Thanks, Convener, and good morning to the panel. I want to speak a little bit round about the offences, the inspection regime and the penalties as they're set out in the bill. Do you think that the current penalties for offences which are set in the bill of up to £5,000 are sufficient to deter unsafe practices? And how could we ensure that we build an effective system that handles persistent non-compliance? Should there be an escalation beyond fines? And if so, what would you want to see in that? I don't know who wants to start. Laura?
Yeah, happy to start. Yes, I mean, I think at the moment for us it seems a proportionate approach to regulation. We already sort of approach any intelligence around unregistered services that do meet the definition in a sort of supportive model to seek registration, and then we would look to do our sort of systematic processes of enforcement. So at the moment, if it was a registered service that was in breach, we would look at improvement notices, we would look at emergency conditions, etc., to try and protect the well-being of the service users and the broader public. I think on the face of it, the proposals are proportionate of where we are. I think your question about repeat offences is an important one. We've got no indication at the moment as to how big a problem that would potentially be or not. What I would say is that when we have concerns of a public safety nature, a public protection nature, we do already work closely with Police Scotland around that, in terms of intelligence that we would share and for them to take forward with the Crown Office. So I think where there is a greater public safety concern, we would absolutely seek to continue those sort of relationships with Police Scotland. And we are aware that obviously within this enforcement power and the extension of the powers from the bill for ourselves, that it would be looking at us building cases direct to Crown Office, Prosecutor Fiscal. So we think that's a proportionate element. The other part for us that maybe beneficial is that we would continue to work and strengthen the sort of MOUs we've already got with other regulators. So again, it's not just about the criminal proceeding part of it, where there are professional registrants. We have already established reporting structures around fitness to practice processes, and we would look to really strengthen those sort of aspects within the bill and utilise those so that it was almost a dual-pronged deterrent. I'm not sure if that's helpful.
Yeah, no, that's very helpful. Brett, from a save face perspective, where are your thoughts around about the offences as set out in the levels that we're proposing?
I don't disagree with what's just been covered. I think the challenge that we perceive is there is a lack of centralised data that identifies actually what are the barriers to safe practice and what types of complications, issues exist within this sector. So while we're talking around repeat offenders, etc., it's difficult to actually understand what the issues are, because if we look at the landscape in Scotland currently, and we raised this concern 8-9 years ago, we're currently regulating what you describe as potentially low-hanging fruit. You're currently regulating healthcare professionals who are operating from fixed premises, and what we're not really getting into the detail of is where the problems arise, or actually understanding the real issues that exist within poor levels of service that the public are exposed to at the minute. So it's difficult to quantify how you'd address this and whether it's appropriate.
Brett, and I think that probably speaks to some of the questioning that I've been undertaking in the last 2 weeks. So I'll perhaps turn to his colleagues to ask around about that inspection regime that's going to need to be there in the non-low-hanging fruit premises, so not the licensed premises, but beyond that. Have you started to think through how that would look in practice, and how you would perhaps do that with health, your HIS, but also environmental health officers? What role Police Scotland would have that, other agencies, etc. How is that going to look?
Sorry, just a point of clarity. You mean for services that are currently unregulated but under the proposal would be registered with us, or sorry,
premises that perhaps would fall out with they should be registered with you, but they're going to be operating under the radar.
Registered but should be regulated. Yeah. So again, at the moment we work on an intelligence-based model. It is very much a supportive mechanism. Most people, when we approach them, either don't realise they're supposed to be registered, and they engage with us. We have a fairly high success rate with individuals. The registration process does have a footprint, and we engage in a supportive mechanism to support with that. What I would say is I think that as part of the growth within this bill and the proposals, probably a large part of this, and it will require both Healthcare Improvement Scotland, the professional regulators and Scottish Government, is the public messaging campaign around that, and the timelines for us to be able to enact and to get services and providers in a position so that they are adequately able to prepare themselves for registration in time, so that we would not be able to essentially regulate everyone overnight at a point in time. So we would definitely require some communication, some public messaging and a time frame to engage with the sector, because at the moment as well, from what has been submitted by Scottish Government with the bill, is it's difficult to quantify the exact number of services that we would be expecting to register and meet that definition.
Okay, thank you. And Paula, from the perspective of your professional body and the membership that you have, should enforcement be paired with education to support practitioners and encourage compliance rather than relying solely on punitive measures? How is your organisation going to support your members going forward?
Yeah, so I suppose, you know, as a professional regulator, we don't have any views on offences, inspection and enforcement. Believe that it's a matter for government, but would ensure that where there are issues identified, as Laura's already highlighted, that we have mechanisms in place for sharing information. So we do have an MOU with HIS, for example, and we also are part of the Sharing Health and Care Intelligence Network. So where we identified issues with fitness to practice, for example, we would share that intelligence. I would come back to whatever is the final position that will be outlined in legislation. We would ensure that there is clarity with our professional membership so that they were aware of the bill and of that new legislation, and making it really clear to professionals working in non-cosmetic prescribing, non-surgical cosmetic prescribing.
Thank you. And finally, is there a role for Police Scotland in this, and what do you think that the role for Police Scotland could or should be?
So I think at almost the end of the chain, there is definitely a role for Police Scotland. We have a low threshold for criminality, and I think that's got to be a key message round about public safety. There is competence and capability, but actually if there is deliberate obstruction, then we are starting to breach into serious concerns about probity issues and indeed their intentions. So we have already a low threshold for discussing with Police Scotland, and I believe there is a strong, though relatively distant type approach with them. We wouldn't want to be heavily engaged with them all the time, but I think it has to be a strong method of how we can go about managing this system.
And from the kind of inspection regime and the intelligence sharing part of it, how important are environmental health officers going to be within our local authorities?
So actually the role and function of HSE is becoming significantly clear during part of the discussions, and I actually have a discussion next week, or sorry, the week after, with colleagues in HSE about secondary and tertiary impact of this, and actually we are very keen to pursue information sharing protocols with local councils. So actually we have a systematic approach to managing all of this, and it doesn't feel or appear the Healthcare Improvement Scotland, plus or minus the professional regulators, are working in a silo. It has to be a consistent approach so that all the appropriate agencies are engaged.
Sorry, Mr. Collins.
Yeah. I think it's just important, because I know we're talking about the future bill. My understanding is through current HIS regulation of independent clinics, is all relevant healthcare professionals who provide face-to-face private services should be operating from a HIS registered clinic. So this in Scotland means there are 4 professional registered backgrounds: doctors, dentists, nurses, midwives and pharmacists, who are required to do face-to-face consultations where toxin is being prescribed for a treatment or any medication used to treat dermal filler complications. And therefore, any doctor, nurse, dentist providing services in this sector in Scotland should already be operating from an HIS registered clinic. Now, within the bill, it estimates between 1,000 and 1,500 clinics or service providers should be registered, which therefore indicates if you can't or shouldn't be getting a treatment in Scotland currently without a healthcare practitioner providing that face-to-face prescription, there's an existing problem that's not been addressed within this current landscape, which ultimately means you've potentially got 500 healthcare professionals that are in breach of the code of conduct set out by the likes of the NMC, as we heard, who updated that guidance in June. And you've potentially got, 500 clinics potentially that are using no prescribers and are using illegally imported, unlicensed or counterfeit medications. And that's the current landscape. There's current legislations in place that requires face-to-face consultations with healthcare providers within this sector, and there's legislation that exists that they're required to be registered with HIS.
Yeah, I think it's very helpful to have that on record, and I think that whoever's coming next is going to be asking questions round about resources for Healthcare Improvement Scotland and operational challenges, and maybe that will be explored, I think, within that context. Thank you.
Brian Whittle.
That'll be me. Thank you, Convener. Good morning to the panel. Thank you for coming forward. I think as a kind of baseline here, we've heard a lot of evidence around the practitioners, the wide variety of practitioners who are involved in this industry, from highly qualified healthcare professionals right the way through to, or down to, those who have maybe been in a couple of days course, and then can go out and ply their trade. So I suppose, how do we make sure that the way in which we deliver this regulation catches the ones potentially that are causing most of the issues? I hesitate to use the word rogue traders, but I think we know they exist. How do we make sure that those are identified and caught, rather than impacting on businesses who are going to be continually compliant, because they're the easy ones to target? I don't know who wants to come in on that. Okay,
so it's definitely a challenge, and as Laura suggested earlier, on the back of this, there is a real opportunity about public-facing engagement, so they understand actually where things are, and to engage with them about what their expectations should be. Certainly, the onus of responsibility sits with the individual practitioners, and should they then bypass all of our standard processes, then it is about catching and sharing intelligence. So could it be stronger? I believe it could. However, at the moment, the mechanisms to do so are quite challenging. There's that piece about a lot of this takes place on social media. It's incredibly difficult to try and observe and manage that. I think colleagues in Police Scotland have shared concerns in other fora about that difficulty with a burgeoning social media presence for types of advertisements. So we are committed to continue and expand. However, there is no doubt it is a challenge within Scotland. I don't know if Laura, you have anything you wanted to add to that?
Yeah, I won't reiterate what Eddie said, but again, we've got already quite good established relationships with organisations like the MHRA and the ASA, where if we have intelligence that's not necessarily within our remit but may fall within theirs, that we will share that information. And again, as Eddie had kind of alluded to, I think in terms of if we do the public messaging bit of what should be reported, so within our remit we can investigate complaints, we do look at notifications of adverse events, and there is something there for us about establishing a more seamless mechanism to report that information, to do a bit of thematics around it, and how we utilise that for the future, and move into sort of medium to long term changes within the independent healthcare sector as well for monitoring.
So I suppose the next question, especially for HIS then, is that if we're going to establish the protocols for ensuring compliance, how then do we practically resource that, and where are we short in terms of that practical resource that's going to be required to deliver this bill?
So thank you. So part of the increase in registration and the fees within that should help support this long term, but to be honest, it is not currently, and it is quite a long way from being a self-financing process. So that continued discussions with Scottish Government round about baseline funding will need to continue, and we have a view as the system expands we are likely to require more to meet that, particularly with those requirements. I have a view, and we have been working towards a systematic approach to over the next 3 to 7 years to develop a self-funding model. But I would suggest, quite rightly, the system is based on public safety rather than a business model. So continuing down that route means there will be a delay while we work towards that. But I think we do have some processes in play that should help the financial system. But at a fundamental level, our baseline funding will probably need to increase. Right now, we are reviewing all of our processes within independent healthcare, so we'll be better able to assess that once we've understood the landscape and indeed the processes within independent healthcare itself.
Laura?
Yeah. So I think just building on what Eddie said, so it absolutely is intended that the equilibrium point would be reached, and there may be a necessity for pump priming initially, but I think as well, just to give assurance to the committee that as part of our review of our sustainable approach for independent healthcare regulation, the fee modelling is part of that just now. That's a review that's currently undergoing, and the other aspect that's within that is also our tackling of aged debt or bad debt, as it may be known. So those are services who maybe have not paid their fees for regulation, and obviously that then bears the cost for Healthcare Improvement Scotland for the regulatory function. So we have recently had an amendment to the overarching NHS Scotland 78 Act, which does allow us to take action for cancellation of services and deregister services where for non-payment of fees. So we are seeking to actively pursue and recover aged debt and outstanding debt, which again should bring us back to that more viable sort of financial position on a medium-term basis.
I'm just going to check if Brett or Paul are looking to come in any of these. Just please indicate.
No, I think, as the professional regulator, we wouldn't have a view on this. It's not within our remit.
I suppose then you kind of led me into this, Laura, around the proactive detection. I mean, again, there's a practical element to that. If that's going to be part of what HIS are involved with, that will require resource if we're going to be proactive about that, rather than passive, if you like, waiting for reports to come into you. So where do you stand in that? Is that something that's going to have to be properly resourced?
I think there is a balance in terms of that sort of risk-based service-by-service approach of how we would approach that. Within the actual Act itself, the duty is on the services to be registered, and so again, as part of that broader timeline and lead-in to any enactment or of the legislation, we would look to engage with those services, with the individuals that we think would fall within it, and help them and support them to understand what the registration inspections processes would be. We already have established networks with it. I know that you've already heard from some of the other sort of groups providing evidence like BAMAN and SCIG and other sort of forums where we already engage with them to try and reach and utilise their networks for sharing information about any changes around our regulatory functions. They also are a great source in terms of sharing that intelligence back with us and how we do it. So I think it's about us building on existing platforms that exist, and there will obviously be an operational element in terms of the workforce training and sort of upskilling of that, all of which we are looking to explore within that current review process just now, in terms of, do we have the right mix of skills, do we have the right people in the workforce, and what does it look like. But fundamentally, the responsibility within the Act as it stands is on the service provider to register with us rather than as HIS to proactively deter. Now, as I say, we would take a risk-based approach to that, and obviously if there's a public safety, that's where we have already utilised those relationships with Police Scotland, MHRA, etc.
I think finally on this particular...
Wants to come in.
Oh, sorry, Brett. Please come in, Brett.
Yeah, I just think the question, we seem to be taking a position that health HIS really were originally developed for regulating hospitals that care for seriously ill and vulnerable patients, and the regulation of healthcare professionals within aesthetics is quite a different landscape. And I think you know, the point I made earlier that there are hundreds potentially of healthcare practitioners in Scotland currently that should be registered with HIS, and there appears to be no clear evidence of a policing proactive approach to ensuring that this current legislation is mandated. And within the bill, there's unquantified complaint costs, which indicating there's no account for any increase in the volume of complaints. But I think, you know, as I mentioned earlier, we're currently regulating low-hanging fruit who are committed to delivering safe services. We're getting into a completely different landscape here, where being mentioned in terms of operators on social media, ghost practitioners, people using products that they shouldn't be using that are coming in illegally into the UK. There's unquantified elements of enforcement costs. And when we're talking about the fact that this isn't going to be something that is cost neutral in the foreseeable future, and the amount of cost and resource that will need to go into this to make it anywhere near effective is particularly challenging. And I think it's disturbing that we're not getting a true feel for what that might look like as part of this bill.
See, I think that's really useful, Brett. I mean, I think that's where my line of questioning is really going here. It's how do we deliver not just a bill that we're trying to make everybody compliant, but how do we do that practically and effectively? And my last question along those lines really is, you know, some of the things I think haven't been considered is you know, enforcement provisions in the bill. How do we address things like, you know, secure storage, you know, maintaining chain of evidence for seized items? How do we including counterfeit medicines? So what's the role therefore of the Scottish Government in ensuring that those issues are taken care of, and you have the basically the tools to deliver the practicality of this bill?
Yeah, so happy to come in on that. I think there are some key points in there. And in our written response, we did say as well around some of the things around power of seizure and covert surveillance. We know that there is potentially some challenges with RIPSA, so Regulatory Investigative Power Act in Scotland. So we would need clarity around any sort of interactions that would impact us in being able to undertake that function. The largest challenge that appears from the evidence that's been provided to us is that we can't reasonably estimate how many numbers of these services there are out there. But we do have processes already established, so whereby if we have intelligence that there are services that should be registered, like say we have structures of from that supportive mechanism up to emergency conditions and cancellation or approaching through Police Scotland. We've also sought clarity around the fact that we are a specialist reporting agency now for direct reporting to Crown Office Procurator Fiscal. So that's a process that we've not operationally implemented previously, but it is an area that we are currently seeking to work towards and what that would look like. So there are areas that we know that we have at our disposal that we need to explore and expand into. Now, as to whether or not that can be done within that cost-neutral envelope, as you've already alluded to, or whether that would require an element of pump priming at the outset, is probably some of that unknown. I think also factoring on to Brett's point about there are potentially hundreds out there acting in this way. We do receive a fairly regular flurry of activity and inquiries through our service at the moment of services that people believe should be registered with us and are not. Now, some of that, because of the nature of the regulation at the minute, they are not, because they provide, for example, dermal fillers, which then does not need a prescription, so does not need a registered professional within the legislation. So what we see here is actually an area or an opportunity to provide clarity for us to actually regulate with more certainty for individuals who make those inquiries to us, because I think Brett's point's well made in terms of what do we do with it. So this would provide us more clarity of making contact with those individuals, starting the registration process, inspecting to a standard, and ultimately assuring the public safety element of that.
Okay, thank you.
Emma Harper.
Thanks, Convener. Good morning to you. Just before I ask my substantive questions, it's just what you just said, Laura, about dermal fillers don't need a prescription. Is that because in the previous session I raised the fact that they are like hyaluronic acid is a medical device, it's not a medication? Is that something that needs to change?
So they are deemed as a medical device, so it's under the MHRA. So that is it's one of the largest areas that we do engage with the MHRA around that, and counterfeit or illicit supplies of medication, which is why we've got those information sharing. In terms of whether or not it should change, I probably can't provide a clear answer on that because I'm not the expert in the medical device aspect of it, but certainly it's an area of sort of dubiety and does challenge us within our regulatory position at the moment. Whereas if we were to say that those are a Group 2 procedure and would need to be carried out from a permitted premises, as what is being proposed within the bill, that should in theory provide more clarity for us in addressing those gaps in the legislation.
Yeah, Eddie.
But it is an incredibly fair point. I think colleagues in MHRA are probably best placed to make an assessment. But going back to the fundamental principles of public safety, I think real clarity from colleagues in that interdependency. So Healthcare Improvement Scotland isn't acting on its own. So where is our relationship with the MHRA on this, and how do we then seek further clarity? Because it may well be that a safer approach would be as a prescribable medication. It's not currently, but they're definitely the experts in the field, so it would be quite difficult to give a definitive answer.
Okay, thanks. So one of the things that, just to touch on what Brian Whittle was talking about, that there's a lot of businesses out there that are providing treatments for people. And so they are the low-hanging fruit, as Brett said, that are easy to detect or find. But it seems that there's more businesses offering non-surgical procedures that are unregulated, that are actually regulated. And paragraph 14 of the financial memorandum talks about numbers and how not all hair salons will be doing Botox, for instance, and even if it is 20%, that might be about 5,000 new businesses that need to be regulated, and whether they come forward and apply, or whether they need to be found. So I'm interested to know, how much time do you think is going to be needed to enable a transition? Because there's going to need to be more people looking into this. There's going to need to be transitional ability for people who do want to apply to have their place of practice made into a HIS clinic area. So what thoughts, what do you think about timelines as we move forward?
I think what we don't want to do is have a date around enactment and then actually we're not in a position to reasonably enact and to the public expectation and to provide that clarity. We would probably anticipate that we don't see this being achievable sort of prior to the 27-28 sort of financial year end point. We probably do need to get clarity around those relationships with direct reporting for Crown Office, clarify some of those information sharing agreements again with local authority, particularly around, you'd mentioned the power of seizure stuff earlier, Brian, as well. I think for us to be able to robustly establish the mechanisms and procedures that we require, and I think also to enable the availability of the data and for much more clarity on the size and scale of the services that we are talking about regulating, it would not be achievable for us within the next financial year to be able to undertake that.
Does the financial bill, the financial memorandum, accurately reflect what you think might be required in terms of investment and then delivery for the transition?
I think yes and no, because it's really difficult when we've got no reasonable means by which to estimate, one, what the level of commitment and confirmation will be from services to engage with that process, and whether or not there are 500 services out there who will all be able to align themselves to a healthcare professional to meet the definition of registration, or whether there will be some businesses who will realign themselves to the local authority licence sort of scheme only. That will give us challenges. I think the other aspect of it is in terms of if we're talking about those sort of reporting mechanisms and how we do that, there are potentially things like IT infrastructure that we would want to try and source and to understand, because just now we take intelligence pretty much through a mailbox or an inquiry line around information from the public or from other services, but actually if we're looking at a more robust reporting process or portal approach, then there are elements like that that we've not reasonably costed because we don't understand the size and the scale at this point in time of what we would be trying to address. So we would maybe see them as a sort of incremental phased approach once we got to the original point of implementation. Would that be fair, Eddie?
Yeah, and I think the phased approach piece is proportionate and reasonable. We have applied this in a variety of areas round about an individual or a group identifying themselves as now required to register with us. If they begin the process reasonably, we then stop that timeline to say they are acting reasonably, and over a time period we then focus on those which are at high risk to go back in and take a very much a risk-based approach.
And you mentioned, Laura, about IT systems, for instance. I know, like, you know, I'm a former NHS Dumfries and Galloway nurse. When there was an adverse incident, we entered it in DATEX, which is now in phase. So would there need to be some kind of tracking mechanism to report error issues that have been, like, somebody's safety has been compromised?
Yeah, so again, really valid point. So at the moment we do have for registered and regulated services a notifications portal. The challenge with that is that some of them are recorded by definition of complication of dermal filler, some are recorded as duty of candour incident, some are recorded as adverse outcome for health or service user, and so there is a mechanism for us probably to engage with our stakeholders and the services that we regulate to ensure there is a consistency to allow us to do that thematic piece. I think, you know, Eddie will probably come in the back of me. There are already, as you alluded to, models within the NHS around the standards we expect around adverse event reporting and those notifications, and I think there's definitely transferable learning that exists within other areas within Healthcare Improvement Scotland.
And I think that is a key point. I'm sure, as everyone is aware, Healthcare Improvement Scotland are moving from a concordance to a compliance model when it comes to adverse event reporting. I think there's significant overlap when it comes to this piece of work and this type of work moving forward, so we actually then can consistently and routinely collect that information. The onus will always be on the individuals taking place, and that's how it works in adverse events. But we already have begun the conversations with a variety of stakeholders on how we can start implementing that, because again, that public safety piece, what went wrong, what can be learned, and is there anything that can be shared across the entire environment?
Okay, and in terms of, I suppose, given the public advice about this new proposed process of regulation of non-surgical procedures, does the financial memorandum cover what might need to be required in order to provide information, wider information to the public about what is coming down the line?
So that, again, we have done quite significant comms pieces in the past. We haven't built that into this memorandum particularly, but we do know that we're likely to kind of draw together funds and approaches across multiple agencies to try and approach this, but it will need to be at scale. But we do have success, and obvious success, with previous changes that have shown we can engage. Would we like it to be broader? Would we like more ability to do so? There's no doubt about it, but we are aware of financial constraints and are trying to work within that.
Okay, just a wee final question. Okay, yes, absolutely, yep.
Brett?
Sorry, I didn't hear my name. Yeah, I think just to bring it back to in terms of the requirements and engagement of clinics and practitioner providers who are not currently engaged with HIS, who maybe should be, and how that would look moving forward. Is there scope to look specifically at a requirement for non-surgical treatment providers, due to the fact that aesthetic treatment is very different to what would be carried out in hospital settings with serious ill and vulnerable patients? Aesthetic treatment's minimally invasive and provided electively to generally fit healthy population. There's certainly requirements within HIS standards currently that are prohibitive to business owners and treatment providers currently. which may be having a negative impact on their willingness to engage in the process. And if that standard isn't reviewed as a fit for purpose based on this specific sector, then the barriers will exist. And if these barriers are unnecessary barriers within a standard, surely that standard should be reviewed. For example, you know, HAS required premises construction and finish standards that have got to adhere to seamless and smooth, impervious, sealed and gap-free surfaces, including coving between floor edge wall, which would necessitate extensively costly structural renovation for existing clinics. And this, in terms of a logical understanding of what these treatments are, how they're carried out, this goes far beyond practical hygiene requirements for aesthetic settings and aligns more with operating theatre specifications. So I think in terms of understanding how many service providers there are out there, which in principle should all be engaging with some form of healthcare practitioner, because we were touching on dermal fillers not being prescription-only medicines. Well, any clinic or service provider offering dermal fillers should also be capable of managing complications. And the reality is, to manage a dermal filler complication, you need prescription-only medicines. And therefore, it's not just in the capacity of HIS and how many more people, how many more departments, how many more infrastructures we create, and IT and AI and things like that. It's actually looking and saying, for this specific sector, is this too onerous? Will this have unintended consequences that are going far too far than actually is required by a service provider? You know, SaveFace for 11 years have been committed to ensuring that the environments that we assess are safe and hygienic and appropriate for the treatments. But that doesn't extend to requiring them to meet hospital standards. It has components, things like sharps disposal, medicine management, and things like that. But currently, the framework of which the standards need to be applied and met are particularly onerous, and the cost and implication of that will continue to be a barrier.
Just a final thought. Okay, it's about vulnerable people that might seek what might be perceived to be too often procedures like dermal fillers, to the point where their physical appearance might be perceived to have been altered, where other people would say that doesn't look good anymore. As part of the notification process would involve maybe flagging up if there is somebody that attends more frequently.
And that would certainly be an ambition. Back to that, all adverse event reporting in any form is about identifying things that have gone wrong or could potentially have gone wrong. And I think this would be a key point in that aesthetics piece. When it comes to adverse events and private sector, I would suggest there's a significant body of evidence for other areas such as heavy industry, where reporting and adverse events have been truly effective and actually changed entire systems. So we do have evidence and are supportive of applying adverse events. The thresholds may look different, and we understand that. However, we do have evidence that private sector will actually work very effectively with this once we go over some initial hurdles.
Okay, thanks.
Sandesh Gohani.
Thank you. I suppose a very basic first question. Who should regulate aesthetic practitioners?
Yeah. So by the nature of how we regulate the independent sector within Scotland, we regulate for the definition of the services and the providers. We don't regulate activity per se, and I know that this has been a question that's been raised because we've obviously got a different model then from the CQC in terms of that activity. So for us, it's about regulating the services, the providers, and then those professional groups within it. If there are non-healthcare professionals who are able to align themselves to the model with the registered healthcare professionals that provide us the certainty and the assurance around the public safety, then that would fall to us to regulate. If it's the group ones, then we believe that they are lower risk and they are suitable for the local authority licensing, similar to how things are already regulated with the tattoo and piercing industry. I would link it back to the point that Brett made in terms of the sort of fixed premise guidance and the standards. For us, the importance of regulating in this approach around independent hostels, independent clinics, is about the consistency of that environmental standard, because it shouldn't really matter what the procedure is and whether it's for a well-being or an aesthetic reason, or whether it's for a sort of physical health need that's been identified. The standards of the environment, the medicines management, the infection control procedures should have a standard. So for us, we do believe that the regulation of the services and the providers and that approach is the right way to go, and therefore those aesthetic procedures or those aesthetic clinicians would need to be able to align themselves with that model for our regulation. Does that?
But the direct answer to my question, not for group one, but is HIS.
Yeah, it's HIS.
Okay.
Yeah.
Okay. Now, do all aesthetic practitioners have insurance? Is that the general feeling that you've got?
So I can comment on that from the general unregulated industry, but as part of the registration process for Healthcare Improvement Scotland, your indemnities and your liabilities as part of the process that we would undertake as part of your registration and your inspections.
Okay. And should we be regulating the individuals, or should we be regulating the premises, or both?
So, I mean, it is, and it probably cuts to the heart of a lot of this work. I think different models will approach it differently. The model we have can definitely expand to cover more parts of the industry. I would suggest there's always going to be an option for a mixed approach. So working with our colleagues in things like the NMC for regulating a professional, that regulation is well established and works extremely well. So actually I think the combined approach is going to be particularly helpful, particularly if we're now saying non-registered professionals need that level of supervision. There will always be debates about what that supervision will look like, but in principle it is a particularly strong option.
So a mixed approach. Now, the NMC regulate nurses that perform aesthetic procedures. How many cases have you had before you specifically for aesthetic malpractice?
So I couldn't give you an absolute figure today, but I can certainly find that out for you. But what we do know, and why we updated our position, was because we were seeing increases in cases around fitness to practice, cases around non-surgical cosmetic procedures, but also around prescribing, particularly remote prescribing, which is why we address that in our updated statement. But I can certainly get that figure for you.
But there are cases that...
Yeah, absolutely, and they're rising, yes.
Okay. And so if you've got a case where you are regulating nurses who are doing aesthetic procedures, how do you ensure that they are up to date with what they're doing and they have the appropriate training in the first place? I know we touched on it when we had the first question, but just sort of expand on that if you may.
So we don't set any specific requirements around education and training specifically for non-surgical cosmetics, but we do have standards around independent prescribing. So we know that this work will require prescription in the majority of cases. So we have standards of education and training for independent prescribing. Our standards of proficiency around that are through the Royal Pharmaceutical Society's competency framework. So that sets out the capabilities. And that is across professionals, allied health professionals, not just nurses and midwives who are prescribers. So we're all signed up to, the majority are signed up to that framework. We also have the code, and as a registrant, talking to registrants, we all know that if we are not aligning to and abiding by the code, then we could well end up having to justify or defend ourselves through fitness to practice processes. So we require individuals on a 3-yearly basis to inform us through revalidation that they are appropriately educated and trained. That would include aesthetics if they are working in aesthetics. So we're really clear that individuals must maintain their scope of practice and make sure that they have the knowledge, skills, education and training required to deliver those services. So we have processes in place around ensuring our professionals are aligning to the code. We have those education and training standards for prescribing, particularly, and our updated position is around remote prescribing and our expectations of a face-to-face consultation in those situations, both at the very start of meeting that individual and that first prescription and every consultation thereafter.
I'm not meaning to pick on nurses. The GMC do doctors, but they're not here for me to ask questions to. So it seems to me, though, that there seems to be a bit of an unlevel playing field here, where if you happen to be a nurse that is doing aesthetics, you are held to a standard where you could be struck off, quite rightly in some cases, right? But if you are not regulated, then you can essentially operate with very little in the way of consequences.
Yeah, and that's a challenge, as we've heard this morning. I suppose our responsibility for those professionals, nurses and midwives, who are often working with unregulated professionals doing, prescribing medications, etc., delegating procedures, is making sure that when they are doing that, whoever is undertaking the procedure is appropriately trained and understands the risk of complications, etc., with those procedures. So we are very clear about delegation responsibilities and ensuring that whoever is being delegated to is appropriately trained and competent. And we're very clear that when something is delegated, that responsibility remains with the individual who's delegated, whether that's through prescribing or otherwise. So we have very clear kind of positions and statements, standards around delegation. We're also undertaking a review of our code at the moment. So the current code has been in place since 2016. As part of that, through talking to...
as you're updating your code, would it be helpful if through this bill there were standards for you to then reference?
Yeah, absolutely. I think, I think it adds clarity. There've been calls for us to look at delegation. So we issued guidance and position statements. If we included everything in the code, it would be 5 million pages long. So there is an opportunity to update, but also have additional guidance around delegation. And there are requests for us to be able to do that. I also think that, our updated position now brings us into alignment with the other health and care professional regulators, in that we all have, we've co-produced high-level principles on remote prescribing as well. So we're all in alignment in this space around cosmetic procedures.
And does the panel, as my final question, does the panel feel that this bill, in the way that it's written, will provide the regulation that is required in this field? And if not, what changes would you suggest we need?
So I suggest it is a significant move forward. I think there's real clarity in the bill and its impact on public safety will be clear. One of the challenges within this type of environment is it is constantly changing. It is a real environment where there's opportunities as social beliefs, social cultural beliefs change. So there is a piece that we will always struggle to be ahead of that. I think the bill is structured in such a way to give yourselves the powers to actually respond to that and make things much more effective. So I think there are some really strong messages coming through from the bill. I don't think it's perfect, but I don't think anything can be perfect, given the nature of the systems that we're working in.
Right.
So I do think that clear identification of competence would be massively helpful, though again, competence changes as the actual methodologies change, so it's possibly difficult to then imbibe that. It may be a case of having a reference point or a requirement that multi-agencies work together to do that.
Build on that. So I think there's 2 points. One is that so I absolutely support the bill, and I do think in the current landscape it is completely proportionate. I think we have to be mindful that the inherent risk of any procedure will not actually change as a result of the bill. This is just about the controls and the mitigations that we put around it to try and improve the public safety. And so that's part of that public messaging, because we're not reducing the risk of the inherent procedure in itself. And I think that's a message we need to be really consistent about. And I do think the other part, in terms of the change that I would really seek to enforce, we are very supportive of not undertaking, and within the proposal, within hospitality and exhibition venues. And therefore I would clarify that point of that non-surgical procedures should be within the independent clinic rather than within the independent medical agency space, which might be, for example, the training that you could have like a training academy that results in the provision of a botulinum toxin to a live model as part of demonstration procedures within like exhibition hospitality. So we would probably look to strengthen the section around that.
Do you write to us with that?
Yeah.
Thank you.
And Mr Collins wanted to come in.
Yeah, just in terms of the bill being fit for purpose, I think, you know, my concerns more fall within how realistic is it to actually bring this into a meaningful and effective landscape. You know, we're talking about, and there's no doubt in terms of NMC, GMC, General Pharmaceutical Council, GDC, have got aligned approaches now in relation to things like remote prescribing. And I think it's something that we can generally say is an issue within the industry. Again, it's how that would be policed, enforced, and importantly, how the public would be educated in Scotland in relation to what to expect when walking into a treatment provider, and that being ingrained in their expectation. And I think in terms of the principles of what we need to make this happen and the volume of resource to make it effective, because, and sorry to bring it back to, we have hundreds of healthcare practitioners potentially operating in Scotland, that there are currently mandated regulations that are not being adhered to and are not being policed and are not being effectively put in place. So I guess my disconnect is what's going to change, and how will this bill extend a process that will ensure public safety. I think the other thing, when we get into delegation, supervision, that changes the landscape significantly. I think what's
Before
important
you
to
continue,
context.
sorry, it's difficult to interact online. What change would you then make?
I think that there needs to be a review of what roles practitioners have within non-surgical, whether they be medical or healthcare professionals or non-medics, what their roles are, and what that, you know, if you are going to look at competency, what that looks like. Because 99% of people that operate, whether they're healthcare or non-healthcare, do attend 1-2 day courses. Maybe they attend many courses over their career in aesthetics, but you will also, and we've got data that supports this, how many healthcare professionals move into aesthetics, get trained on a 1-2 day course, and then have to reinvest in additional training because they don't feel that the training they receive or access initially is comprehensive enough to help them feel confident and competent. You know, that's something that exists within healthcare. It also exists within non-healthcare, and there currently isn't what I would consider a fit-for-purpose solution around education and training. There's also the retrospective, how do you bring that up to date and how do you safeguard moving forward? That'll be in place for future generations to access resources and training that will be fit for purpose and will facilitate future-proofing as this industry evolves, as it changes shape, as new treatments evolve, etc. So I think in terms of we can develop a fit-for-purpose bill in principle, but if the realities of the landscape, the enforcement, the policing, and the public awareness are not also in place, it won't dramatically improve the landscape and address the issues that most ethical treatment providers want addressed, whether that be healthcare or non-healthcare.
Thank you.
Patrick Harvey.
Thank you, Convener. Good morning. I'd like to ask about the consistency of regulation. In the first case, consistency between the different parts of the UK. Now, one view says that we should generally err on the side of consistency and regulatory alignment because it's simpler to communicate, it's easier for everyone to understand, and it avoids unintended consequences about people moving between different jurisdictions for one reason or another. Another view says that alignment for its own sake isn't a good priority. We should only align if we're aligning with something that we think is the right regulatory position. We shouldn't adopt a lower regulatory position just for the sake of alignment. And in terms of where the decision sits, again, one view says that the devolved government and Parliament in relation to devolved matters should decide, is divergence justified to achieve a public policy objective like patient safety? Another view, embodied in the Internal Market Act, is that the UK government should decide in the interests of market alignment and fairness for market operators, if you like, to impose a common approach. Can I ask for your general view about, first of all, whether alignment between the different jurisdictions in the UK is important? Does it matter? Are there any unintended consequences? And to what extent the level of divergence or difference that's proposed in this legislation is workable, manageable?
So, again, I think you've made some incredibly strong points. Where we are just now, I would suggest that mixed model approach of how we go about managing registration and regulation is workable and can improve. We would always want to seek learning from other aspects of not just the UK but across the world. But I think being proportionate and reasonable, I don't think there's a perfect answer to that, to be honest. I think as long as we remain proportionate, fleet of foot and prepared to seek more information, i.e. are the CQC doing something which is particularly helpful or definitive, and then map that across. We already have very strong relationships with senior teams in CQC, so do seek that type of information regularly. So one size may not fit all, but I think both models are workable, but actually I don't think there's a perfect answer.
And the divergence between the two, you don't see problems arising from that in principle?
Everyone works towards the same principle about public safety. And I think as long as that remains enshrined and core to what we're doing, every group will work proportionately. The actual scale, volume and indeed activity within Scotland and England, for example, are not identical. So therefore our ability to respond locally is potentially extremely helpful.
Any other views?
Yeah, I would just say in terms of professional regulation, you know, our updated statement has brought us into alignment with the other professional regulators, which has been helpful. I suppose we constantly are reviewing the legislation across the 4 countries, so we understand that there are different systems in place and work within that legislation to ensure that our professionals are working within that legislation, if you like. And I suppose I'd just like to point out that, you know, Scotland has different legislation which has started conversations around holding prescription-only medicines, particularly emergency supplies within establishments which carry out non-surgical cosmetic procedures, and actually that's been a real positive. That started conversations in England and debate around that area. So I think anything where we can align, does help to mitigate some of the public protection risks and provides assurance to members of the public. So consistency, oversight and alignment where possible, I think, is important.
And when you talk about that Four Nations dialogue that takes place, are you talking about that purely within your own professional colleagues, or are you aware of that happening between governments as well?
Both.
Okay.
So yeah, in all kind of areas that you would imagine, with government, with chief nursing, chief midwifery officers, we have an employer liaison service which works across a regional footprint, which have regular conversations with senior professionals within organisations as well. So, yeah.
Anything to add?
Yeah, I would probably just build on what Paula said. I think that fundamentally there would be a slight shift in our overarching legislation for us to bring unity, but actually in a principles-based approach, we are all kind of working collaboratively. The cross-regulator platform and cross-regulator forums are exceptionally helpful, and they are well established. And really how we would sort of perceive the bill as it's proposed just now in Scotland would be a sort of levelling up of that public safety aspect of it. So we would almost justify that as the rationale for the divergence.
It's inevitable that the closest comparisons that we make in a regulatory issue like this are with other UK nations. But should we also be looking at that wider kind of global picture? There will be, if we raise standards to a regulatory level that we're happy with here, there will be people who perhaps get encouraged to go on holiday and get procedures done unsafely somewhere else. Is there anything that we can or should do within this bill that would address the issue about information or awareness or promoting access to services in other jurisdictions, other countries? Is there anything we can do in relation to that to address safety?
I mean, I'm not sure entirely how feasible it is within the bill in itself, but I think health tourism is certainly becoming much more common terminology that we're hearing, and certainly the complications of that. So I think any sort of shared learning that we could do within it, or anything around the advertising of health tourism from Scotland, would certainly be a strength within the bill. I think if we could try and limit that. We are aware of advertising within again, exhibitions, conferences, professional magazines, etc., for aspects of health tourism. So if there could be anything to prevent such aspects, that would be a strength. I'm not sure if that's possible or achievable or not.
Mm-hmm. Yep.
No, I was just going to say it's how feasible is that within the bill, but we certainly undertake a lot of international mapping around all of the work that we do. So I'm aware of the same challenges within Australia that are happening, and we regularly have conversations with our counterparts in Australia and European countries around some of these challenges. So it is about having an open dialogue around some of these issues, but I think it's incredibly complex, isn't it? It's hard enough across the four nations of the UK, but there is certainly something that is worth exploring, I think.
Thank you. And the only other point on consistency...
Briefly, Mr Harvey, we're due to finish at 12 o'clock.
In that case, I'll stop there. Thank you.
Thank you. I know that Mr Collins wanted in, perhaps if he could submit what he wanted to say to committee in writing, that would be greatly appreciated. And I'm sorry to have to rush on, but committee does have more work to do this morning. So can I thank the panel for their attendance, and I will briefly suspend till our changeover of witnesses. The third item on our agenda is consideration of one affirmative instrument, the Food Safety Act 1990 Amendment Scotland Regulations 2026. The purpose of the instrument is to amend provisions of the Food Safety Act 1990. These regulations restate secondary assimilated law within the meaning of Section 12, brackets 2, brackets B of the retained EU Law Revocation and Reform Act 2023. Regulation 2 amends Section 17 of the Food Safety Act 1990 to replace references to EU obligations and provisions with assimilated obligations and provisions, and replaces a reference to directly applicable EU provision with provision of assimilated direct legislation. The Delegated Powers and Law Reform Committees considered this instrument at its meeting on the 18th of November 2025 and made no recommendations in relation to the instrument. We'll now have an evidence session with the Minister for Public Health and Women's Health and sporting officials on the instrument. And once we've had any questions answered, we will proceed to a formal debate on the motion. And a welcome to the committee, Jenny Minto, Minister for Public Health and Women's Health, Emma Luton, a lawyer, and Greg Walker, Project Lead, Constitutional Policy Unit, Scottish Government, and Jennifer Howie, UK and International Relations Team Lead, Food Standards Scotland. And I invite the Minister to make a brief opening statement.
Thank you, Convener. I'm pleased to join you this morning to consider the draft Food Safety Act 1990 Amendment Scotland Regulations 2026. As the committee will be aware, food safety standards and labelling is an area on which I am advised by Food Standards Scotland. The proposed minor technical amendments arise as a consequence of the UK Government's decision to leave the EU and the need to ensure that the statute book in Scotland remains operable. Food Standards Scotland worked diligently with the Food Standards Agency and the Scottish Government to update EU law references to retained EU law references where they were found. This particular instrument relates to a deficiency contained within the Food Safety Act 1990. This Act provides the legal foundation for food safety and standards in Great Britain. The amendments to the Food Safety Act 1990 were originally going to be made by a GB statutory instrument. However, once it became apparent that the GBSI was being paused, the Food Standards Agency and UK Government by the Food Standards Agency and the UK Government, the responsible approach agreed between Food Standards Scotland and the Scottish Government was to take forward a Scottish statutory instrument instead. This serves to enhance the clarity and accessibility of the devolved statute book and gives the Parliament reassurance that orderly preparations are being made in Scotland for EU reset. I would stress that these amendments are technical in nature and do not amount to any change in policy. They are necessary to ensure the statute book is brought up to date. There is no impact on businesses or any other stakeholder group. I ask the committee to agree to the proposed instrument and I'm happy to take any questions.
Sanders Gohani.
Thank you, Convener. Thank you for coming, Minister. It's a technical change. Before this change will happen, was there any implications to industry?
In what respect?
In any respect. So in the way that it's written right now, is there any implications to industry that might be as a consequence for the way that it's written right now?
So the reason for bringing in this SSI is to return the statute book to the way that it should be. It wasn't updated. It still talks about EU law, which is no longer factually correct. It is now assimilated law. So that's the change that's being brought in, and that therefore allows us, with the work that the UK government is currently doing to improve relationships with the EU. Now, of course, the Scottish Government believes Scotland's best interests are to rejoin the EU as a independent member state. But until we get to that point, I think it's important that we rebuild the close relationship that we have, and therefore the current EU reset work that is happening, when that happens, then we have a statute book ready to integrate that quickly and efficiently.
Thank you, Minister. I've got no indication that any other member wishes to ask a question. So we'll now move to agenda item 4, which is the formal debate on the instrument on which we've just taken evidence. Can I remind the committee that officials may not speak in the debate? Minister, can I ask that you move and speak to motion S6M 19531, lodged by yourself?
Thank you, Convener. I move the motion.
No member has indicated that they wish to contribute to the debate. Minister, is there anything further that you wish to say?
I have nothing further to say.
So the question is that motion S6M 19531 be approved. Are we all agreed? Yes. Thank you. Committee is agreed. And that concludes consideration of the instrument. The fifth item on our agenda today is consideration of a negative instrument, the National Health Service General Ophthalmic Services Scotland Amendment Regulations 2025. The purpose of this instrument is to deliver the full implementation phase of a policy to support independent prescribing optometrists and ophthalmic medical practitioners to manage patients with 10 complex acute anterior eye conditions under general ophthalmic services, reducing the number of these patients needing to be referred to the hospital eye service. The Delegated Powers and Law Reform Committee considered the instrument at its meeting on the 18th of November and made no recommendations in relation to the instrument. No motion to annul has so far been received in relation to this instrument. Do members have any comments? I propose that the committee does not make any recommendations in relation to this negative instrument. Does any member disagree with this? At our next meeting on Tuesday the 16th of December, the committee will conclude its scrutiny of the non-surgical procedures and functions of medical reviewers Scotland Bill, taking oral evidence from a panel of witnesses on Part 2 of the Bill, followed by a concluding evidence session with the Minister for Public and Women's Health. And that concludes the public part of our meeting today.